அவர் அழகு யாரு இல்ல அவன்கிட்ட கை கொடுத்துறேன் பத்தியா அதுக்குள்ள வச்சுட்டுன்றேன் அவன்தான் அண்ணன் உங்க இடத்துல கேட்டாங்க நான் 2 சொல்லி வச்சிருக்கேன்
அண்ணாமலை சொல்லிட்டு இருந்தாரு பண்ணல சார்
படிச்சேன் அப்புறம் பாதியில விட்டுட்டேன். சத்தியமா சொல்றேன் நான் இது ஜெனரல் முடிச்சிட்டேன். சிவிஎஸ் பாதி முடிச்சிட்டேன். அப்புறம் நர்வ்ல ஒரு 3 வீடியோ முடிச்சிருக்கேன். அதுக்கப்புறம்
இல்ல லேப் பேக் இது கொடுத்துருங்க நம்ம இங்க
அக்பர் சார் குட் ஆஃப்டர்நூன் சார்.
ஓகே
குட் ஆஃப்டர்நூன் சார். அக்பர் குட் ஆஃப்டர்நூன் ரவீந்திரநாத்.
ஓகே
ஓ என்னன்னா நல்லா இருக்கீங்களா? நல்லா இருக்கேன்.
சார் குட் ஆஃப்டர்நூன் சார்.
செந்தில் சார் குட் ஆஃப்டர்நூன் சார்.
சார் குட் ஆஃப்டர்நூன் சார். சார் ரவி சார் வந்துட்டீங்க? எஸ் சார். ரவி சார் வந்துட்டாருங்க?
ரவி வந்துட்டீங்களா சொல்லிருக்கேன்.
எஸ் சார். ஃபைன் சார். சார் ஸ்டார்ட் பண்ணிடுவாங்க.
பிரேயரும் பிசிஷியன் பிரேயரும் அவருக்கு விட்டுருங்க.
சார் குட் ஆஃப்டர்நூன் சார். ராஜ்குமார்
அந்த உங்களுக்கு இதுல பாத்துட்டீங்களா?
நான் பாத்தேங்க சார், எடுத்துட்டேங்க சார், 2 எடுத்துட்டேன்.
சரி சரி.
மகாராஷ்டிரா லாகின் பண்ணுங்க.
வீடியோ என்ன கட்டாயி தானே இருக்கு வீடியோ. நீங்க கட் பண்ணிருக்கீங்க. அது ஒண்ணுமே
வேற ஏதாவது யூஸ்ஃபுல்லா வாங்கிக்கலாம் சார் டிபார்ட்மெண்ட். அந்த ஆரோ வாட்டர்லாம் பழசா யாரு ஸ்கூட்டி இதே மாதிரி இன்னொரு சார் இதே மாதிரி 1 லட்சத்துக்கு உட்காந்துட்டே இருந்தோம் அது வாங்கி போகணும்.
செந்தில் சார் செந்தில் சார்
சோஃபா மாதிரியே இருக்கும் அது வாங்க
கூப்பிடுங்க
சார். சார்
இருக்கேன் என்ன
முருகன் சார் எல்லாரும் லாகின் பண்ணிட்டாங்க.
லாகின் இது ஆரம்பிச்சிடலாமா? வில் ஸ்டார்ட் தி மீட்டிங்.
ஆமாங்க சார், ஸ்டார்ட் பண்ணிடலாங்க சார். அன்மியூட் பண்ணிடலாம். டாக்டர் ராஜசேகர் சார் எல்லாம்
டாக்டர் செந்தில் டாக்டர் செந்தில்
Hello. Dr. Sendil, shall we start the meeting?
Yes, sir. Yes, sir. We can start the meeting, sir. Yes, sir.
மத்தவங்களை அன்மியூட் பண்ணிட்டு ஸ்பீக்கர்ஸ் ஹோஸ்ட்ல
அக்கௌண்ட்ல போடுறாங்களா இல்ல கேஷ்?
சார் அவர் கிருஷ்ணன் சாமிநாதன் சார்
సురేష్
Good evening, sir.
OTP வந்து
we'll start the meeting, sir.
Yes, we will start the meeting.
இல்ல, அது உங்களுக்கு taxable ஆகும்.
Yes,
Good
sir.
evening,
Now
Raghunath,
it's
sir.
4 o'clock.
இல்லாட்டி அவங்க tax குடிச்சிட்டு தான் வந்திருப்பாங்க. ஜனம் வந்தீங்கன்னா உங்களுக்கு
ரைட்டோட போடுவாங்க.
நல்லா இருக்கிறோம், அடிக்கிறோம். நம்ம உடம்புல மயிலாட்டிங்க நீங்க பேசினா நீங்களே பேசுற மாதிரி இருந்தா என்ன நல்லா இருக்கும். உங்களுக்கு புரிஞ்சிருக்கு சார்.
Sir,
yes, sir.
So, Murulan sir, unmute பண்ணுங்க sir.
Sir, sir, unmute பண்ணிக்கலாம்.
Okay.
Sir.
Yeah.
Yes, sir.
Now only you unmuted me.
Yes, sir.
Good evening,
Now we are
everyone.
host, sir. Good evening,
Am I
sir.
audible?
Yes, sir. Very much audible, sir. Good evening, sir.
Good evening. Good evening.
Sir,
Yes,
I think
sir.
Krishnan
It's
sir,
already
mic test பண்ணிடுங்க sir.
Yes, sir. Sir, சொல்லுங்க sir.
கிருஷ்ணன் சாமிநாதன் சார் ஒரு வந்துட்டாருன்னு பாருங்க.
இல்ல, அவர் வந்திருப்பாரு. அவருக்கு கோர்ஸ் பண்ணியாச்சு சார். அவர் அடுத்த ஸ்பீக்கர் தான் வந்திருப்பாரு சார். நான் இப்ப பாத்துறேன் சார். இப்ப நம்ம ஃபர்ஸ்ட் ஸ்டார்ட்
அவரோட தானே சார் டாக் ஃபர்ஸ்ட் வரும்.
இல்லைங்க சார், சாரோட ஃபர்ஸ்ட்.
சரி ரைட்டுங்க சார்.
இப்ப கோர்ஸ் வந்தாச்சு சார். அவரு வந்துட்டாரு
சார்.
எஸ் சார்.
ஓகே. அன்மியூட் பண்ணனும் அவரை.
Charge இருக்குன்னு.
ரவீந்திரநாத் அன்மியூட்.
Yes sir.
சார் மாலை வணக்கம். டாக்டர் சுவாமிநாதன்.
சார் வணக்கம் சார்.
Swaminathan, Krishna.
Yeah, sir, great to meet you, sir.
Sir.
Sir, கேக்குதா சார்?
Yes sir. வந்து உட்காருங்க. வந்து உட்காரு. முதல்ல ஆரம்பினா அதான் ஆரம்பிக்கல. காய் போடாம ஒண்ணும் போடாம.
Sir, second one, sir. Shall we start, sir?
Sir.
Rajshekhar sir வந்துட்டாரு இல்லைங்க sir? Yes, sir.
Rajshekhar has come.
Yes, sir.
You make him also co-host. Rajshekhar, Krishnan Swaminathan.
Yes, sir.
Done, sir.
Yes, sir. Done, sir. Second one, sir. Shall we start, sir?
Sir, Krishnan Swaminathan sir unmute பண்ணுங்க sir.
Sir, our sir. He can unmute himself, sir.
Okay.
பண்ணிட்டேன் சார். கேக்குதா?
Yes, sir.
Yeah.
Rajkumar.
Sir, no problem, sir.
Rajkumar, please introduce Rajshekhar because he will start the meeting once the webinar comes. After all the formalities,
Okay.
Before we start the webinar, we'll ask Rajshekhar to give an introduction and then he'll do the moderator job. Rajshekhar, are you ready?
Sir.
Rajshekhar?
Yes, sir. Yes, sir.
Yes, sir. So now we will formally start the meeting, sir. Meeting call to order. Now, Rabindran sir?
Yes, sir.
Yes, sir. Kindly proceed, sir, with the IMA prayer and Christian prayer.
Good evening, sir. IMA prayer. எல்லோரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலி என்னும் தொல்லை நீங்கி, அல்லல் செய்யும் இன்னல் நீங்க, பேராசை பிரதிபயன் அகற்றி, பிணிப்போக்கும் பெரும்பணி ஆற்றுவோம். Physician prayer. எல்லாமல்ல இறைவா, உலகில் சிறந்த மருத்துவன் நீயே, உன்னை மண்டியிட்டு வணங்குகின்றேன். உன்னிடமிருந்து நல்லதும் சிறந்ததும் என்னை அடைய பிரார்த்திக்கின்றேன். எனது கரங்களுக்கு திறமையை தாரும், எனது மனதிற்கு தெளிவான பார்வையை தாரும், இருதயத்திற்கு இரக்கத்தையும் கனிவையும் தாரும். எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் எண்ணம், வாடும் மக்கள் படும் பாட்டினை சிறிதளவாது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையும் தாரும். என் மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு குழந்தை போன்று உன்னை சார்ந்து வேண்டுகின்றேன். தேங்க்யூ சார்.
Thank you, sir. Now I request Sengutuvan sir to give his welcome address. Sengutuvan sir?
You have to unmute. Dr. Sengutuvan has to be unmuted.
Yes, sir. I think sir has left now and now he has joined again. Sir, kindly unmute, sir. Sengutuvan sir, kindly unmute, sir. Sir, I think sir will be joining, sir. And today's meeting is regarding lifestyle management diseases, hypertension and diabetes by eminent speakers and stalwarts. So I think today will be a wonderful academic piece. And I request all our members to stay throughout the program and enjoy the session. And it is not only for credit hours, kindly stay tuned throughout the session. Thank you, sir. Yes, sir. Thank you, sir.
Unmute. I'm not able to unmute.
Sir, you can only unmute, sir. You are made a co-host now. You can just unmute, sir.
I'm not.
Sir, உங்க வாய்ஸ் கேக்குது. செங்கட்வன் சார் வாய்ஸ் கேக்குதுங்க சார்.
I'm audible.
Yes, sir. நீங்க பேசுங்க சார். கேக்குதுங்க சார். பேசிடுங்க சார். Yes, sir.
I welcome to this forum, today's forum, life disease management. I welcome Dr. A. Muruganathan, who is well known to this field and authority in hypertension, and he is the senior-most, one of the senior-most physicians in India. And I also welcome Dr. Krishnan Swaminathan, who is going to speak on the diabetes and diet management, everything. I also welcome Dr. Rajasekhar, who is going to be the moderator for this program. And I also welcome all the participants to this program and stay till the meeting is over. Thank you.
Thank you, sir. Now I request Dr. Rajkumar sir to introduce the moderator and also the speakers, and we will start the mini session.
Good evening, respected members. I'm very proud to introduce our moderator for this session, Dr. Rajasekhar, one of the senior-most physician in the Kaveri Delta region, right from Tiruchi to Kadalur. Dr. Rajasekhar is one of the renowned physician who is practicing at Kumbakonam, and he is a senior consultant physician and diabetologist at Heart and Diabetes Therapy Center at Kumbakonam, and he is traveling along with our Dr. Muruganathan for so many years in the field of research and study about hypertension and diabetes for a long time. We welcome you, sir. We are proud to have you here. And our speaker, Dr. Krishnan Swaminathan, sir is endocrinologist who is practicing at Maduram Diabetes and Thyroid Care Center, Coimbatore. He has completed his undergraduate medical education from Madras Medical College and higher specialty training in diabetes and endocrinology from renowned centers at United Kingdom, Cambridge and Scotland. He is a MRCP holder in 1999 and he has done his PhD from IIT on agrochemicals and diabetes. He has more than scientific publications in his, and he is the founder trustee of Idayangal Charitable Trust, with whom, with which he is serving underprivileged diabetes children. And he is an author of a Tamil book called Samaniyanum Sakkarai Noyum, in which he has demasked all the queries about diabetes for the in Tamil simple Tamil language for the ordinary layman also. We welcome you, sir. We are proud to have you. And last but not the least, we are very happy to have our Dr. A. Muruganathan. He is who needs no introduction. He is very well known all around the world. He is former emeritus professor of Tamil Nadu Dr. MGR Medical University, and he is international advisor for Royal College of Physicians, Glasgow, and he is a chairman of IMA Hypertension Standing Committee. He was a member of Tamil Nadu Medical Council, and he was the past governor of American College of Physicians India chapter. He is past president of our IMA state, Tamil Nadu state, and he is the dean of IMA Indian College of Physicians, and his credibility is and his work in the public in the field of medicine. It's a very long list, and we cannot complete this session if we start talking about that in detail. So, in short, I am very proud to have Dr. A. Muruganathan for this session. Thank you, sir. Thank you, and we welcome you all, sir. Thank you. Sandil, sir.
Yes, sir. Sir, Muruganathan, sir, over to you, sir.
Now Rajshekhar will take over. Rajshekhar, please just give your brief introduction about those two topics, and I will take over.
Yeah, sir. Thank you, my mentor, Dr. N. Muruganathan, sir, and organizing committee, CGP Secretary, Dr. Sandeep Kumar, and Dr. Raj Kumar for inviting me to be the moderator of the session. These are the two important diseases. Hypertension and diabetes is a deadly duet. It is a Tom and Jerry. So, whenever a patient comes, a basic investigation, that is checking the BP, and capillary method, that is the blood sugar, we rule out the two major diseases. We all know hypertension is an abnormal elevation of blood pressure due to increase in cardiac output and peripheral vascular resistance. There are, we all know what are all the drugs we use, and Dr. Muruganathan sir is going to highlight it. And Dr. Krishan Swaminathan, and is a well-known endocrinologist, and is going to speak on OHS, because most of the patients will not like to have insulin injectables, only they want to have OHS. We all know diabetes is a hypersecretory senescent state due to glucotoxicity, lipotoxicity, oxidative stress, amylin deposition, insulin receptor substrate, resulting in programmed cell death, that is apoptosis. And Krishan Swaminathan will highlight it, how to prevent it. First, let us have the first topic, Dr. A. Muruganathan sir, that is the hypertension management. We will go one by one. Let him share the slides. Please, sir. Over to Dr. A. Muruganathan.
Is my slide visible?
Yes, sir. Yes, sir. Very much.
Yes, sir.
Yeah. So, good evening, my dear brothers and sisters. It gives me immense pleasure to participate in the CGP program. When I was the Dean IMA CGP, I only initiated a lot of IMA courses, what we are doing now. I'm very proud to say, I was the one person who started this, and it is going very well. And having seen the response, I think I request Sendil and Rajkumar and Sengutu, and you should have frequent programs like this. Maybe we can organize master class also like this. Now I see more than 1,000 people are there. So I think people are interested in learning. So I think every month we should have 2-3 programs like this, and we'll update all our members. Thank you very much, Rajkumar, for the introduction. And Sendil, thanks for inviting me to participate. You had been asking me for quite some time. That's why I thought we have chosen 2 topics about Krishnan Swaminathan. He's not only a good communicator, he's a good human being. He has adopted more than 1,000 children, type 1 children, for whom he gives the insulin, he gives refrigerator, glucometer, and proper checkup. And he really adopts them all over the Tamil Nadu state. So he is a very good person. He's going to talk about the oral anti-diabetic drugs, good, bad, ugly. That's the topic. And I'm going to talk about the hypertension. Now I'll come to my topic. Once again, thanks for all the organizers. And Rajshekhar is one of the, we always call him as WhatsApp professor. We are running nearly 30 WhatsApp groups. In all our WhatsApp groups, every day, he only educates so many people. So those of you who are interested in joining our WhatsApp group, please contact us, and you will have academic feast every day in the morning, thanks to Professor Rajshekhar. With this, I'll go to my topic, hypertension management. The flow of my talk will be introduction, diagnosis, target, nighttime BP, time in target, well-designed combination pill, indices to assess consistency of BP control, BP variability, 24 hours control, choice of treatment according to risk factor, HMOD, and comorbidities, new devices and drugs, and conclusion. The discovery of blood pressure was more important than the discovery of the blood itself. John Muller, a German anatomist, said. So blood pressure is very, very important. In and day out, we see lot of cases of hypertension and diabetes. Hypertension in India, we got more than 22 crores of people with hypertension, and another 20 crores of people are waiting to get hypertension. Whether you are a dentist, whether you are a obstetrician, whether you are a surgeon or a pediatrician, hypertension is part and parcel of your practice. So every day, everyone will get hypertension patients. So everyone should be aware, because the morbidity, mortality, and prevalence of hypertension is 3 times more than diabetes. That is why every one of you should be aware what to do, what not to do, what is the treatment, what is the lifestyle modification you give. I think first of all, I congratulate Sendil for choosing the topic as lifestyle modification, which we require in our day-to-day practice. Now coming to this, this man is the Christian Bernard. He had done more than 150 heart transplant, and he said at the end of his career, I have saved the lives of 150 people by heart transplant. If only I focused on preventive medicine like hypertension, I would have saved 150 millions. My dear brothers and sisters, you are the savior. Every day you see so many patients of hypertension and control. So you are much, much better than Christian Bernard, who can save lot of lives. Every one of you in the periphery, saving lives, treating gastroenteritis, treating fever, treating many illnesses, and you are saving. By transplant, in a month, he saves 1 patient. That too, with all very complicated difficulty. But whereas every day, as a practitioner or a physician, we treat and save many patients. So we must be proud. And on this Doctor's Day month, I congratulate all of you for the noble service what you do. Now, hypertension is a global health challenge with high prevalence, low control rates. The early introduction of combination therapy is very important. Nowadays, all the guidelines says even before, first, when you see the patient first time also, you start combination therapy. Another point which all of us should remember, the hypertension, whenever there is a blood pressure control, you should control the blood pressure 24 hours, not only in the morning. See, when somebody comes in the morning in the office or clinic, the blood pressure is under control. We don't know what is his blood pressure in the night. So this is called nocturnal hypertension, which can be diagnosed by only ambulatory blood pressure monitoring. And not only that, your blood drug, the concentration, the effect should be all the 24 hours. Suppose you give a drug, it acts only 6 hours or 12 hours, then it is no use. So we call it as time in target. And there should be no BP variability. Many times the BP variability, see morning one BP, evening one BP, and after 1 hour some BP. So this is BP variability is not accepted, because BP variability is another problem which can cause a lot of complications. So 24 hours BP control, and to get this time spent at target blood pressure level must be useful as a clinical management. Hypertension can improve the quality in the real world treatment effectiveness. Okay, what are the paradox for hypertension? Easy to diagnose, but often remains undetected. Simple to treat, but often remains untreated. Despite availability of potent drugs, often treatment with all is ineffective. See, most easy to diagnose is hypertension. If you have a good, proper machine and then measure properly, easy to diagnose. Even simple to treat. The point simple to treat, but often remains untreated. Despite availability of potent drugs, the treatment with all is ineffective. In spite of the incidence, morbidity, mortality more than diabetes, we see only few specialists in hypertension. We can see diabetologists nook and corner of all the country, or even small towns. This is the special article called Satak lecture, who also said the number of people with uncontrolled blood pressure is increasing despite therapeutic advances. Now, diagnosis of hypertension. How do you diagnose hypertension? There are three ways of diagnosing hypertension. One, clinical BP. That is, when somebody comes to your clinic or office, you check the blood pressure. That is clinical blood pressure. That is office blood pressure. One should not diagnose only with office blood pressure. If somebody has got hypertension, you should counter check with home blood pressure monitoring or ambulatory blood pressure monitoring outside the office. Many guidelines say by simple office diagnosis, you should not treat. You should counter check with office BP, home BP or ambulatory blood pressure monitoring. This is the ambulatory blood pressure monitoring. Many of you know this. We tie up in the arm, and then connected to the battery cell with the electrodes on the chest. It will record the blood pressure for 24 hours. We don't allow you. We allow you to do normal work, whatever you do. Suppose you play tennis, you can play tennis. You can do every work as per normal routine. And at the end of the 24 hours, you get the recording. And this is the definition of hypertension by office and out of office blood pressure level. The office blood pressure is 140/90, whereas in the ambulatory BP, daytime is 135/80, 135/85. In the night time, it should be less than 120/70. If somebody has got more than 120/70, we call it as hypertension, the night time, nocturnal hypertension. Average 24 hours BP must be 130/80, and the home BP also, it's 135/85. These are the guidelines, lot of guidelines from JNC 7, JNC 8, ACC, AHA, Korean guidelines, NICE guidelines. We have our own Indian hypertension guidelines by our API, Canadian guidelines. All these guidelines vary. The definition varies from 120/80, 130/80, 130/85, 140/90. Don't worry about all that. These are the important guidelines which you see. European guidelines is 140/90. ACC guidelines 130/80. ISH guidelines again 130/85. WHO guidelines 140/90. So it may be confusing why they say 140/90, 130/80. In fact, American guidelines says 130/80. If somebody has got above 130/80, you must call them as hypertensive, start treatment. But whatever the international guidelines, the goal is 130/80. If somebody can tolerate 130/80, and that is the goal you should aim for and control the blood pressure. So whoever has got blood pressure, try to bring systolic blood pressure around 130 and diastolic blood pressure 80. If the patient can tolerate. Sometimes if you lower down so much, somebody may have some giddiness problems. So individually you can see, but generally, if you can bring it to 130/80, that is the goal and that is the desirable goal. I told you threshold. If you see, practically, when the patient has got coronary artery disease, heart failure, CKD, diabetes, the risk is more than 20%, or the person less than 65 or more than 65, but still active, independent, tolerant, you can reduce the blood pressure up to 130. It is if the patient has got post-stroke, low risk, more than 65 or less than 65, frail individual with multiple comorbid condition, you have to bring down only to 140. Decide according to biological age rather than chronological age. So whenever you have anybody above less than 65 years, target is better than 130/80, and above 65, 140/90. Of course, individually, depending on his comorbid condition, the target varies. This is the ambulatory blood pressure. Whenever you see a patient, you get a record like this. This is called nocturnal dip. Normally, everybody during night time, there is a fall in blood pressure. This is normal. You can see if the blood pressure from here to nocturnal dip, you see 10% of the original pressure. So if the dip is more than 10%, it's called extreme dipper. If the dip is not there, you say non-dipper. If the dip is not there or raising, it's a raiser. So these are the people who will have a lot of problems and who will have nocturnal hypertension. So when you do ambulatory blood pressure monitoring, you can see the nocturnal dip as well as early morning surge. This is early morning surge. As soon as the patient gets up, the blood pressure is more. So nocturnal dip and early morning pressure is very important. That's why we use ambulatory blood pressure monitoring. And again, this is the ambulatory blood pressure monitor reading in the clinic blood pressure, and this is the nighttime pressure. If you see, the cardiac events are more during the nocturnal hypertension, when the patient has got nocturnal hypertension. Even the clinical blood pressure is 170, you can see the events is 1.5. Whereas the same 170 during nocturnal or nighttime, it is 3 times more. So, which means everyone should be aware about the nocturnal hypertension. Try to detect nocturnal hypertension by doing ambulatory blood pressure monitoring. And of course, all of you know, I think my slide is hidden. You have to check the blood pressure in certain position. You should not use the regular stool because that slide has not come. I think it is the slide is hidden. You should not use the round stool what we normally use. When a patient comes, you ask them to sit quietly with the back supported, with the feet firm on the ground, and the cuff, BP cuff at the heart level. And they should not have smoked earlier, about half an hour earlier, no coffee, no urge to pass urine, and he should be calm and quiet. No mobile phone for either doctor or the patient during the checkup. So this is how you have to check the blood pressure. Unfortunately, that slide is not coming. I'm trying to get it, but it's not coming. So this is the very important. Accurate blood pressure measurement is the key. I request and suggest, and those of you who want this acute blood pressure measurement video, we can share with you that you can put it in your clinic outpatient reception room, so that even the patients who buy home blood pressure monitoring will learn how to measure blood pressure. This is very important, and every clinic should have this video, or you should educate the patients to do home blood pressure monitoring and teach them how to use the home blood pressure. I told you nighttime BP is the true predictor of cardiovascular mortality. So the message is, all of you, please promote home blood pressure monitoring. All of you record BP properly, and then look for nighttime BP, which is a true predictor of cardiovascular mortality. Now, this is the another thing. Now, there is two terms you must understand. What is mask hypertension? Mask hypertension is the patient has got normal blood pressure in the office. The blood pressure is more in the house or in the environment. So this is mask hypertension. So you will all diagnose this mask hypertension by doing home blood pressure monitoring or ambulatory blood pressure monitoring. Another hypertension is called weight coat hypertension. What is weight coat hypertension? The blood pressure in the clinic is high by seeing your weight coat or weight dress nurse, whereas the blood pressure is normal at home. So that also can be diagnosed with home blood pressure monitoring and ambulatory blood pressure monitoring. Compared to weight coat hypertension, mask hypertension is more dangerous. You should identify mask hypertension, and then you see, for example, daytime the blood pressure is very well normal, whereas the nighttime it is more. And when you give a drug which acts only 8 hours, the blood pressure is under control. So anytime you check in, the blood pressure is normal, whereas in the nighttime it is more, or outside the office the blood pressure is more. So this is called masked hypertension. And then weight coat hypertension. Weight coat hypertension, normal blood pressure outside the clinic, more pressure in the clinic, whereas masked hypertension, normal pressure at the clinic, more pressure at the outside. So now coming to the another terminology, I've told you what is masked hypertension, what is weight coat hypertension, nocturnal hypertension, and then ambulatory blood pressure monitoring and home blood pressure monitoring. Now coming to the systolic blood pressure time in target range and cardiovascular outcomes in patients with hypertension. I told you, whenever you give a drug, that drug should act 24 hours, and the drug concentration should be always there. Even for insulin, when you give insulin, insulin dosage should be there 24 hours, so that every minute, every hour, the blood pressure is under, the blood sugar is under control. Same way anticoagulant. When you give anticoagulant, 24 hours, that action should be there, so that throughout the day, it be there. So in time and target, even if one standard deviation increases cardiovascular events, non-fatal myocardial infarction, you can see hazard ratio 0.81, 0.75. And then we did one of the largest study called Caliber study fashion, where they found out more than 16 lakhs of reading under the 1,50,000 patients, found that this time and target is the key to find out whether the pressure, whether they have any problems. For example, if you see in the blood pressure variability, only the hazard ratio is 0.2. If the time and target is missing, the time and target is missing more than 3 months, you get hazard ratio of 0.8. If the time and target is completely normal between 9 to 11 months, the risk is only 0.17. If it is not there, the risk is more than 100%. So I think not only you have to check the pressure, you must check the pressure throughout the year, and all the months, you should have the pressure control. That is why time and target is another terminology which you should know. So now coming to the treatment, how to control nighttime pressure, how to treat masked hypertension, how to keep more time in target. So these are the things which you should do. I think I have chosen these topics because you would have heard day in and day out a lot of things about hypertension, but these are the main things which we normally forget. So I thought time and target, masked hypertension, and nighttime BP, you should know, and you should suspect, and you should know how to treat these conditions. For treating all these things, you should have a well-designed combination pill. always, I told you, even in the first time when the patient comes, you use combination pill. So well-designed combination pill. What is well-designed combination pill? I'll come one by one. Okay, before that, before you start the treatment, you always subject the patient for lifestyle modification. Lifestyle modification, physical activity. You have to engage them, regular aerobic physical activity, brisk walking, at least 5 days a week. DASH eating plan. See, we always talk about DASH eating plan and we don't follow. The DASH eating plan, you should consume diet rich in fruits, vegetables, and low fat, at least 3 to 4 servings. By doing this only, you can reduce the blood pressure to 8 to 14 systolic. And then salt restriction. Alcohol, no alcohol, even moderate alcohol consumption in the net, you can see. Recently, last week, there was a paper. You should not take alcohol. Alcohol produces problem. Whatever alcohol you think is good, it's not because of the alcohol. It is because of your healthy, human being, healthy individual. That's how moderate alcohol, they say they can reduce 2 to 4. But in my opinion, don't take alcohol. Alcohol is dangerous, especially after the last week new paper. And weight loss, every kilo weight loss, you get 1 millimeter reduction. So weight loss is important. Stress reduction. This is what everyone should emphasize. You have always hurry, worry, hot curry, and worry. So you have to have stress reduction, and you have a good sleep. Very, very important, good sleep. You must have 7 hours of good sleep. If you have good sleep, you can also have immunity raised. During COVID time, there was a lot of paper. People who has good sleep, the immunity, the IL-12 increases, and it is very good. So good sleep is important, and tobacco cessation, no smoking. Now coming to the drug treatment, there are 5 classes of drugs: ACE inhibitor, ARB, beta blocker, CCB, and diuretics. These diuretics again, thiazide and thiazide-like diuretic like chlorthalidone, indapamide. All these drugs are very useful. Certain guidelines say they will not give beta blocker in the first line, whereas India, we also promote beta blocker as a first line drug. Above generally is not a general, but one clue, less than 55, we give ACE or ARB beta blocker. More than 55, we give diuretic and calcium channel blocker. I was talking about smoothness index. It reflects the degree of BP reduction over the entire 24 hours period. And then tough peak ratio. What is tough peak ratio? The ratio between the BP reduction at the end of the between interval and BP reduction at the time of the maximum trough effect. For example, if you give amlodipine, the maximum effect is after 2 hours. The same effect should continue 24 hours. So tough peak ratio. And then you should also avoid BP variability. And these are the drugs that has got 24 hours BP control. What are they? Candesartan, telmisartan, periondropil, amlodipine, and nebivolol have the highest tough peak ratio. So achieving 24-hour BP control, you should have also highest trough peak ratio along ARBs, along diuretics, ACE inhibitors. Candesartan, telmisartan, periondropil, amlodipine, and nebivolol have the highest trough to peak ratio. And these are the drugs which has got long-acting drugs. I told you the drugs what we use is ARB, ACE inhibitor, diuretics, beta blockers. In the ARB, the longest acting is telmisartan, 24 hours. In the diuretics, chlorthalidone, 40 milligram, 40 hours. And in ACE inhibitor, periondropil, 17 hours. Beta blockers, bisoprolol, 12 hours. In the calcium channel blocker, amlodipine, 30 to 55 hours. So whenever you select a drug, it should be long-acting. It should have a high trough peak ratio. And if you see this, 24 hours BP control, select a drug with long-acting. Already told you, amlodipine and chlorthalidone, etc. Now, I'll go to the next slide, where BP variability. If you see, calcium channel blocker and non-loop diuretics reduce BP variability, whereas ACE and ARB increases BP variability. So you have to have a drug which reduces BP variability. So I told you, one, your drug should be long acting. Number two, it should reduce BP variability. It should also have trough peak ratio highest one. So reduction of early morning BP with combination of amlodipine and telmisartan gives the earliest, reduction and reduces early morning surge. This benefit is corroborated by the higher PP ratio and smoothness index for these two molecules of telmisartan, amlodipine. And this is a summary of the drugs which are good. If you stay ACE inhibitor, 24 hours reduction, yes. Early morning surge, yes. Nocturnal dipping, yes. But BP variability reduction is not there. When you take calcium channel blocker, 24 hours reduction is there. Early morning surge also reduced. Nocturnal dipping also reduced. And BP variability reduction also reduced. So when you choose the drug combination, you take the combination of CCB, calcium channel blocker, ARB, CCB with ACE inhibitor, or CCB with diuretic. So you have to select the combination. Now coming to the combination. How do you combine drug selections? I told you what are the advantage of combination versus monotherapy. You have an additive and synergetic effect on blood pressure when two complementary classes of antihypertensive agents are used in combination. For example, blunting or mitigating the side effects of each other as well. For example, renin-angiotensin-aldosterone system inhibitor can reduce the pedal edema often experienced with calcium channel blocker. By which I mean, if you give amlodipine calcium channel blocker and telmisartan combination, calcium channel blocker may produce pedal edema. And when you give ARB, telmisartan, that pedal edema can be mitigated. The recently published systolic blood pressure intervention trial that is called the new trial, sprint trial, where the blood pressure was achieved less than 120, they have required more than 2.7 agents, which means combination therapy only helps. Large clinical trials have shown persons are more likely to achieve early, more rapid control of blood pressure, improved clinical outcomes, including stroke, when combination therapy is initiated in the initial period. Improved medication adherence and persistence also if you do combination therapy. And this combination started in 2003 by JNC 7, 2007, 2017, and 2018. Now recently also WHO and Indian guidelines, we always say combination therapy even in the first phase. European guidelines specifically notes ACE and ARB plus CCB diuretic combination therapy is the choice. The approach has been reinforced in 2020 by International Society of Hypertension and recently by WHO for the pharmacological treatment in adult. Both the HEART's technical package and WHO also algorithm says 2 medications. WHO has included several options in its most recent list of essential medication. And this is the advantage. When you give CCB, it causes arterial vasodilatation. When you give ARB, it decreases vascular volume as well as produce both arterial and venous dilation. That is why when you give CCB, you may have edema, but when you give ARB, which has got both arterial and venous vasodilatation, edema is subsided. So fixed dose combination improves patient compliance, resulting in more consistent and cost-effective hypertension management with favorable adverse event profile. Now, ladies and gentlemen, look at this. When you give telmisartan 40 milligram, 6.59 reduction. Same telmisartan, you give 80 milligram, double the dose, 12.2 reduction. Whereas, if you give telmisartan with hydrochlorothiazide, the combination leads to 18.8. Thereby, doubling the single drug, only less reduction, whereas combining with another drug can produce 18.8. That's why combination is preferable. So ideal now, the international guidelines, international hypertension guidelines says, even when step 1, when somebody comes, you start with A plus C, that is amlodipine, ARB or ACE inhibitor with calcium channel blocker. You start, for example, low dose combination. Telmisartan 40 milligram and amlodipine 5 milligram. One single tablet. First step, you give half tablet. Second time, the same, you give 1 tablet. Third time, you give not only amlodipine, calcium, ARB, ACE inhibitor, calcium, you can add diuretic. So 3 drug combination. When there is a resistant hypertension, Along with this, you add spinal electrode. What is resistant hypertension? When the pressure is not under control with 3 drugs with optimal dose, including diuretic, if the blood pressure is not under control, it is called resistant hypertension. I repeat, when somebody has got 3 drugs, for example, amlodipine, telmisartan, and chlorthalidone, still the pressure is not under control with optimum dose of all the 3, and one of them is diuretic, it is called resistant hypertension. Now, I told you international hypertension guidelines also gives you the step 1, step 2, step 3, which I said of tablet. But whenever drugs are used, whatever drugs are available with as many as ideal characteristics, use free combinations if special single pill combination are not available. Use thiazide diuretic or thiazide like diuretics if it is not available. Use alternative to CCBs. Now, these are, I have already told you, initial therapy, one pill, dual combination. Step 2, then again triple combination. Step 3, 2 pill, triple combination of spinal electrode. This is again drug strategy of hypertension and other comorbidities by the British Hypertension Society, European Hypertension Society, and International Hypertension Society. Always consider beta blocker at any treatment step when there is specific indication for their use. Example, heart failure, angina, post-MI, atrial fibrillation, or younger women who are planning pregnancy. So don't withhold beta blocker whenever there is a compelling indication. When there is a specific indication of angina or heart failure, you should add beta blocker. The advantages of fixed combination: the compliance, efficacy, tolerability, and price and simplicity is better. So prefer fixed combination. And then now there are a lot of papers, triple drug combination, how it is useful. They found out triple drug combination and the monotherapy or double drug combination. Triple drug combination, the effect is good. So it's called polypill. You can achieve high titer achieved in triple pill combination. I told you titer means all the 24 hours the blood should contain the antihypertensive drug and which can produce 24 hours control. So high titer achieved in triple pill better than the monopill or single or double pill. This is a recent paper, and you can see the how it is reducing compared to the usual care polypill. Now I'll go to the last part of my talk. Okay, how do you approach a person with hypertension after ruling out secondary cause? Whenever you have any hypertension, you must rule out secondary hypertension, primary hypertension or secondary hypertension. Secondary hypertension, it can be due to endocrine cause, renal cause, or renovascular cause. You must have a suspicion when somebody comes with sudden high BP in a younger age or an older age. When somebody has got a blood pressure and suddenly it is not under control. So you always have a suspicion of secondary hypertension, and then by the history, you can have a suspicion and do certain basic tests to rule out secondary hypertension. So I'm not going to detail about secondary hypertension. I'm talking about the pharmacological treatment of the primary hypertension. You look for 3 things. 1, what are the associated risk factors? Number 2, is there any target organ damage or complication? 3rd, concomitant disease or condition. So whenever a person comes, if there is a simple hypertension, you can treat with any drug, which I told you 5 class of drug: ACE inhibitor, ARB, calcium channel blocker, beta blocker, and diuretic. In these 3 conditions, you must use specific drug in a specific person, individualized. Now we talk about personalized medicine, precision medicine. We talk about precision medicine, which means it's a personalized medicine. So look at one person who has got any risk factor, any target organ damage or concomitant disease. If there is no these 3 factors, you can treatment in the absence of compelling indication for specific therapies. Whereas if you have these 3 conditions, or either one of them, risk or target organ damage or concomitant disease, you individualize the treatment. Now I'll come to the one by one. First, I said you can see target organ damage, risk factor, and concomitant disease. Now I'll take first target organ damage. We call it as hypertension mediated organ damage, HMOD. Hypertension mediated organ damage. First, left ventricular hypertrophy. This is one of the hypertension mediated organ damage where you get left ventricular hypertrophy. You can use ARB, ACE inhibitor, losartan, calcium channel blocker, indapamide. Don't use vasodilator, hydralazine, minoxidil can increase LVH. Now, if the hypertension with coronary artery disease, CAD, beta blockers, RAS inhibitors, irrespective of BP levels, with or without calcium channel blocker, are the first line drugs in hypertensive patients with angina or ischemic heart disease. What are the drugs? Metoprolol, carvedilol, bisoprolol, ramipril, and periandropil. You don't use direct vasodilator. Now, hypertension, heart failure. Again, this is HMOD, hypertension mediated organ damage, is a risk factor for the development of heart failure with reduced ejection fraction and with preserved ejection fraction. Heart failure, we classify whether the heart failure with reduced ejection fraction or preserved ejection fraction. I think when you do echo, they'll come with EF of 30, 40. So this is a two types of failure: reduction, reduced ejection fraction or preserved ejection fraction. Carvedilol, metoprolol, and metoprolol long-acting bisoprolol can be given along with ARNI or ACE inhibitor or valsartan, and aldosterone antagonist, loop diuretics can be given in the heart failure with reduced ejection fraction. And then heart failure with preserved ejection fraction, now we use SGLT inhibitor also in this cardiovascular, heart failure with preserved ejection fraction. Now coming to the stroke, when somebody has got hypertension with stroke, it can be prevented by BP control. I'll give another message. If somebody develops stroke, definitely it is a problem for rehabilitation, for post-stroke problem. What you can do, prevention is better than cure. The most common cause of stroke is hypertension. So if only you can control hypertension, you can prevent so many strokes. You can prevent disability in life. For example, if a 42-year bank manager gets a hypertension and he goes for stroke, his whole life and family suffers. So instead, if you can prevent the stroke by controlling the blood pressure, you are doing a lot of good things, not only for him, for the country, because the workforce is always there without disability. BP should be lowered less than 140/90 and treated to a target of less than 130/80 in elderly patient. What are the drugs? RAS blocker, diuretic, CCB or first line drugs. Periandropril, indapamide, and amlodipine can be used. There is a progress trial where evidence for ACE and indapamide is always there. So these are drugs which you can use for stroke. Now, kidney disease. When a chronic kidney disease with proteinuria, always start ACE and ARB if tolerated. Additive therapy, thiazide diuretics. If volume overload, loop diuretic like metronidazole can be given. Other agents, if ACE or ARB, can be used. Calcium blocker, alpha blocker, hydralazine, and clonidine. And ACE and ARB should not be given in a secondary hypertension where there is a bilateral renal artery stenosis. And you must always watch creatinine, monitor potassium when you start on ACE and ARB. Always combination of ACE and ARB should not be given, recommended. So whenever kidney disease, when you take drugs, you use in the renal preventive preserving drugs, and you should not use drugs which can increase proteinuria. The best drug is ACE and ARB. If there is no contraindication, that can be done. But caveat is always check the creatinine and monitor potassium. If the potassium increases, then you should be very careful. If creatinine increases more than 30 or potassium more than 5 point, eGFR fall 24%, reassess or refer them to higher center. Now I finished HMOD. Now I am coming to the risk factors. I told you three things: hypertension mediated organ damage, risk factor, and comorbidity. Now the second point is risk factor. If somebody has got diabetes, if the blood pressure is more than 130/80, if the albumin is there, albuminuria, you always start with ACE and ARB. In a diabetic hypertension, ACE and ARB. If BP are not under control, add calcium channel blocker. If BP is still not under control, add carvedilol, which is a metabolically neutral drug. And then even then, if there is no control, you can add alpha blocker, aldactone. If there is a coronary artery disease, you give ACE and ARB. The BP is not under control, the same procedure like this. Now, lipid disorders, BP should be lowered as done in the general population, preferably with RAS or CCB. Beta blocker can be carvedilol and bisoprolol can be used. I told you. Diuretic indapamide is better. Statins are lipid lowering treatment of choice with additional BP lowering. So I am also one of the medical advisor of the Lipid Association of India. We always insist you should give statin whenever somebody has got complications and risk factors, especially diabetic hypertension and hypertension above 50 years. If they have more risk factors, start them on statin. And then now tobacco, if somebody uses smoking, beta blocker may not be effective. The DHP and calcium channel blocker and ARB is better. Now, metabolic syndrome, whenever somebody comes with hypertension, you look for metabolic syndrome. Not only you measure the blood pressure, you measure the waist size also. The waist size, even if somebody is lean, if they have a protruded abdomen and the abdominal obesity is there, that is the villain. So in Indian phenotype, many people you see they are lean, but they have obesity. These people are notorious, they will have all sorts of problems. So in these cases, you check for the blood pressure and put them on ACE or ARB. When there is a salt non-compliance, you always use DHP, carvedilol and bisoprolol. This calcium channel blocker, amlodipine, carvedilol, bisoprolol, when there is a salt sensitive individual, ACE inhibitor and beta blocker may not be effective. Now, the most important thing, erectile dysfunction. In a young person who has got hypertensive, always prefer calcium channel blocker, ACE inhibitor, ARB, especially valsartan, ARB valsartan, because erectile dysfunction is a problem for many young hypertensive. When you start them on drugs, that drugs itself can produce impotence. So when there is a compelling indication, you use bisoprolol and nebivolol. Sleep apnea, you can always, it's one of the cause for secondary hypertension. When somebody has got sleep apnea, you always get the history from the spouse, whether he's got snoring. ACE inhibitor, aldosterone inhibitor, like spironolactone have specific role because spironolactone not only reduces the blood pressure, it also reduces the upper respiratory, upper pharyngeal edema. Always look for sleep apnea and refractory hypertension. Avoid beta blocker. And when you do sleep study, apnea, hyperpnea index is more than 15, we use CPAP. And comorbid condition, last one, when there is a uric acid and hypertension, hyperuricemia, we can use losartan, which will be good for reducing uric acid also. And whenever you use other disease like HIV or you do some drugs, you always see which drug is interacting with the antihypertensive. Avoid those drugs, especially when you use HIV drugs. You should check the problems. Diuretics, the drug interaction is unlikely to occur. Whereas in a losartan, you can see COP inhibitor is there, and then every drug has got action. So ACE, beta blocker like atenolol does not react with other drugs. Metoprolol reacts with certain drugs. So check the drug reaction whenever you give another drug for any disease. Hypertension is most frequently commonly seen with COPD, bronchial asthma, emphysema. So you can treat the target less than 130/80. The drugs of choice is calcium channel blocker, DHP and ARB. Suppose if they have cardiac problem, bisoprolol, nebivolol can be given because these are the selective beta blockers. Now, when you treat rheumatoid arthritis or any arthritis, you may give NSAID. Whenever there is NSAID, you avoid hypertension. Now, to be avoided in hypertension, if NSAID is required, calcium channel blocker, the drugs of choice, because ACE inhibitor may be less effective. So when somebody has got NSAID, they are taking NSAID. If there is hypertensive, you always give calcium blocker. And of course, rheumatic disorders, again, I told you, you avoid NSAID, but now biological drugs have come. And even psychiatric disorders, there may be drug reaction. You avoid CCBs because sometimes psychiatric drugs can produce orthostatic hypotension. What is hypotension? when somebody has got blood pressure, you ask them to stand for 3 minutes and the blood pressure falls more than 20. This is orthostatic hypotension. Any elderly person look for orthostatic hypotension. And in a diabetic patient, you also look for postprandial hypotension. So hypertension, hypotension also very, very important you must be aware and suspect and measure. Now, the last one, devices and drugs. What are the devices used? Nowadays, a lot of smart watches have come and newer gadgets have come. Just for completion's sake, we have now home blood pressure monitoring, which also can diagnose 24 hours BP. Now there is a latest model where you get this called night view blood pressure in the home run. This measures in normally home blood pressure monitoring, but if you tie up in the night time, it measures 2 a.m., 3 a.m. and 4 a.m. So you don't need ambulatory blood pressure monitoring to cover 24 hours. Even this home BP monitor is useful, which has come in the market now. Now this is the blood pressure mobile, and there are a lot of apps have come, and artificial intelligence has come. So this is again artificial intelligence is now incorporation of artificial intelligence in the BP control. The algorithms that can learn from data without being programmed on purpose where to look. So this is again now come in the market. There's a telemonitoring. For example, you give the home blood pressure monitoring at home, and you can monitor from your hospital. So telemonitoring is possible, especially during COVID. We did telemonitoring for many patients, and home blood pressure monitoring was very useful in COVID time because patients could not come directly to hospital. Now, wearables and smartwatches, I already told you, there are a lot of advantages of wearables, and fitness watches are there. And now this is very good, and also the accurate measurement is is there, and all the guidelines have approved certain watches, certain apps. You can buy them and then you can use them. And then this is called BioBeat, then smartwatch from Samsung, smartwatch from Apple. There's a cuffless BP. Now I told you ambulatory blood pressure monitoring is quite not comfortable, but nowadays there are some ambulatory blood pressure devices have come which are very useful, patient friendly. Now the new drug has come called Fibrostat. It is the first new therapeutic class of targeting brain-renin angiotensin system controlled by angiotensin 3. It's a brain aminopeptide inhibitor, useful where ACE or ARB not effective, like obese blacks and low renin hypertension. So ARNI and SGLT also now we have started using for hypertension. ARNI for heart failure, sometimes hypertension. SGLT2 inhibitor is a revolutionary drug. It's a molecule game changer, which is also used in heart failure and heart failure with preserved ejection fraction and things like that. Now, these are the devices which we use called renal denervation. Renal denervation is nowadays available in many centers when there is a refractory hypertension. Now, what is refractory hypertension? Somebody has got 5 drugs, even then the blood pressure is not under control. It is called refractory hypertension. Resistant hypertension, 3 drugs, one of them should be diuretic, or use optimal dose. That is resistant hypertension. The refractory hypertension, 5 drugs we use, still it is not under control. In these patients, you use devices like renal denervation, or there are a lot of newer devices have come. You can see cardiac neuromodulation therapy, and then this is the radio frequency based renal denervation, and also you can see baroreflex activation therapy, application of baroreflex, transvenous carotid body ablation, and central iliac arteriovenous coupler. These are the devices which are useful for persons who are not controlled by controlled by drugs. And now this is the last slide. How do you approach a person? Clinician sequential flow chart for the management of hypertension. First, measure office BP accurately. Whenever somebody comes, you check the pressure. I told you in the sitting posture, back supported. Then rule out white coat hypertension. What is white coat hypertension? Patient's blood pressure is high in the clinic, whereas it is normal at home. Detect white coat hypertension, and then also detect mass hypertension. What is mass hypertension? Blood pressure normal in the office, it's high in the house. So evaluate for secondary hypertension. I told you, you rule out secondary hypertension. Then introduce lifestyle. First, identify target organ damage, rule out secondary hypertension, identify target organ damage, and then you introduce lifestyle modification. Even if the blood pressure is normal, tell them how to take good sleep, how to control stress, and then give them diet advice. Then identify and discuss treatment goals. Use ACVD risk estimation to guide BP threshold during therapy. Align treatment options with comorbidities. Account for age, race, ethnicity, sex, and special circumstances in antihypertensive treatment. Initiate antihypertensive pharmacological therapy. I told you combination therapy with long-acting drug. Ensure appropriate follow-up. Very important. Many educated patients also take the treatment for 1 year, but they stop. Even the doctors, they stop abruptly. So you should have follow-up. Nowadays, WhatsApp has come. You send a WhatsApp message, ask them to come back. The Indian Hypertensive Control Initiative, it is an initiative by the Government of India and state governments, WHO, ICMR, and so many other agencies. I am one of the senior advisor for them. We have now, got simplified protocol, proper follow-up. I'm very pleased to tell you, out of 32 lakhs of patients we treated, more than 50% of the patients are under control. Compared to the overall Indian statistics, less than 12% are controlled. Whereas in our Indian Hypertensive Control Initiative, we got 50% of the control. And for that, recently, the International Hypertension Society and WHO gave an award for the Government of India. So then you always use team-based care. Connect patient to clinician via telehealth, telemetry, telemonitoring, telehealth. Detect and reverse non-adherence. Very important. Many people, they will not take blood pressure. So non-adherence and clinician inertia are two important things. What is clinician inertia? When somebody comes, the blood pressure is 150, 94. Okay. You come next time, we'll increase. Don't do that. That is clinician inertia. You should avoid. You should treat the patient aggressively to get the target. If there is no contraindication, if the patient can tolerate, bring the blood pressure to 130/80. So non-adherence is the patients do not take treatment properly, discontinue. So non-adherence and the clinician inertia are the two important things for not controlling hypertension. Detect weight coat or mass control, then use health information technology for remote monitoring and self-monitoring BP, and use the newer gadgets. Now you see this patient, this person is laughing, very happy. You think he's very happy? No. You see this, the full picture. He's obese, he's got a lot of problem. When that person comes in the clinic, the blood pressure is normal, whereas his blood pressure is more in the night. So just seeing only a half picture, you think he's very happy. No, he's not happy. You see the full picture, you see the full monitor, full picture of throughout the day, then treat. So kindly promote whole blood pressure monitoring, promote the concept of hypertension clinic and hypertensionologist. Unfortunately, we don't have any hypertensionologist, hypertension specialist in the country. So promote that concept. Wherever you are, you start hypertension clinic, focus on hypertension, maintain hypertension registry, promote home blood pressure monitoring. Home blood sugar monitoring is popular, but not home blood pressure monitoring. I had been talking about this for last 10 years. So far, I have given 12,000 monitors in a tribal area and poor people with the support of so many industries, and I'm promoting home blood pressure monitoring. This home blood pressure monitoring is very good, very good. It costs less than 2,000. And once you buy, this can be used for the whole family, father, father-in-law, son-in-law. Also, no investment, like, strips and pricking is not necessary. So I conclude, given the dismal of hypertension control, both high and low middle income countries, the treatment strategies, primarily pharmacological, employed in the past few decades have not succeeded. Now, patients, when they come, you start them on combination therapy. You also give the long-acting drugs. You should also individualize the drug, whether he has got any risk factor, number one, whether he has got comorbidities, whether there is any hypertension mediated organ damage. If those three things are there, you specify that treatment. Otherwise, you can give any drugs, the 5 groups, ACE, ARB, calcium channel blocker, diuretic, and beta blocker. You select the drug according to the indication and then try combination. And then more important is make sure the patient adhere and your inertia is not there. For proper follow-up, proper investigations. You must check the blood pressure also with basic investigations. Also monitor blood urea, creatinine, and echo in case if there is any other problem. Now, one strategy is move from monotherapy to combination therapy as the initial management of most individuals. And I already told you, reduce mass hypertension, suspect mass hypertension, treat nocturnal hypertension, to have time in target, long-acting effect to reduce BP variability. Now, one control over his diet, takes regular exercise, has time to relax, has the right toil in his discharge of his duties, observes proper hours of sleep and awakening, and is balanced in his actions and reactions, emotions and reasons, duties and rewards, can't cause disease, says Bhagavad Gita. So, ladies and gentlemen, it's high time that we focus on hypertension and give education for hypertension and make sure our country has got very good control of hypertension. By thereby, you can prevent a lot of heart attacks, paralysis, renal failure, ophthalmological problem, etc. Thank you. I'll be very happy to answer any question. Over to the moderator.
Sir, thank you, sir, for highlighting extensively by mentor, Dr. Muruganathan, about hypertension, systemic hypertension. So, shall we start the discussion now or at the end of questions on?
Whatever you feel.
Sir, can we have it after the second session? Okay. So that it will be interactive very much. It will be useful.
Okay. No problem. No problem. Okay, yes. Over to Krishna. Krishna, you can take over.
Dr. Krishna Swaminathan, over to you. Who is going to highlight the OADs?
Screen Terida, sir. Is it
very well seen.
And is it moving?
Yes.
Okay. Every Tamil audience, Tamil Nadu state, Tamil
Krishna, you are always good in Tamil. நீங்க வந்து நிறைய punch dialogue எல்லாம் கொடுப்பீங்க. ரஜினிகாந்த் பத்தி எல்லாம் பேசுவீங்க, விஜய் எல்லாம் பத்தி பேசுவீங்க. I think you do that way. That is good also.
You can combine both. Those some North Indians may be there.
Okay.
Actually, Krishna, some of my good friends from North India have joined. That is why I spoke in English. Otherwise, I would have also followed your punch dialogue. But because of that only, I spoke in English. You can speak in Tamil.
You can intermittently.
Okay. மனமார்ந்த நன்றிகள் அனைவருக்கும் இனிய மாலை வணக்கங்கள். First of all, it's such a privilege and honor to be talking alongside Dr. Muruganathan. Sir, he's a friend, philosopher, mentor, and guide. So, நிறைய விஷயத்துல பயங்கர support. So, thank you, sir. Rashik, sir, thank you for hats off to all the work you're doing for educating our doctors, and thanks to all the attendees. இன்னைக்கு ஒரு கிறிஸ்பா ஒரு அரை மணி நேரத்துல ரொம்ப ஒரு nuts and bolts oral drugs in diabetes, good, bad, and ugly. எனக்கு பேஷண்ட்லாம் ஒரு கவலை சார், சைடு எஃபெக்ட் இருக்குமா அப்படின்னு. முதல் பஞ்ச் மேரேஜ்ல இல்லாத சைடு எஃபெக்ட் மாத்திரைகள் இருக்காது அப்படின்பேன். ஸோ சைடு எஃபெக்ட் இல்லாத மருத்துவமே கிடையாது. ஸோ வாட் இஸ் குட், பேட், அண்ட் அக்லி தெரிஞ்சு இட் பிகம்ஸ் ஈஸியர் டு ட்ரீட் அவர் பேஷண்ட்ஸ். அண்ட் இட்ஸ் கிரேட் டு கிவ் அ டாக் வித் நோ கான்ஃபிளிக்ட் ஆஃப் இன்ட்ரெஸ்ட். ஸோ எந்த ட்ரக் கம்பெனி ஹானரேரியம் கிடையாது. ஸோ வாட் யூ ஆர் ஹியரிங் நவ் இஸ் வாட் ஐ ஃபீல் should be done for someone with diabetes. So, ஏற்கனவே டயபிட்டிஸ் ஒரு அமைதியான கொலையாளின்னு சொல்றோம். இது உருளைக்கிழங்கு சேப்பங்கிழங்கு பத்தி கிடையாது. It is a vascular disease with a high risk of heart attack, strokes, kidney failure, amputations and blindness. அதனால நிறைய டைம் சொல்லுவேன், நான் பேஷண்ட்டுக்கு நல்லதே பண்ண வேண்டாம், கெடுதல் பண்ணாம இருந்தாலே பாதி பேஷண்ட் பொழைச்சிடுவாங்க அப்படின்னு. So doing good matters, but doing no harm matters more. So அந்த பேலன்ஸ் நமக்கு தெரியணும், எப்படி யூஸ் பண்ணும் ட்ரக்னு. ஸோ பஞ்ச் ஒன்று என்னன்னா, ஒரு மருந்தை எப்பொழுது உபயோகிக்க வேண்டும் என்று தெரிவதை விட எப்போது யூஸ் பண்ண கூடாதுங்கிறது தெரியறது ரொம்ப ரொம்ப முக்கியம். எனக்கு முருகனான் சார் சொன்னார் நிறைய ட்ரக் இன்ட்ராக்ஷன்ஸ் பத்தி. we need to be very cautious, look at the patient in front of us. இவனுக்கு கிட்னி ப்ராப்ளம் இருக்கா, லிவர் ப்ராப்ளம் இருக்கா, ஹார்ட் ஃபெயிலியர் இருக்கா, இதெல்லாம் வச்சுதான் நம்ம ட்ரக்ஸ் யூஸ் பண்ணோம். And no side effects equal to no effects. அதனால பக்க விளைவுகளே இல்லாம ஒரு மருத்துவம் இருக்கு அப்படின்னா அந்த பக்கம் தலையெடுத்து படுக்க கூடாது. And all drugs are dangerous. Even அன்னைக்கு ஒரு patient vitamin D வந்து வாரம் ஒரு முறை கொடுக்கிறது பதிலா டெய்லி 15 நாளைக்கு கொடுத்து vitamin D intoxication with hypercalcemic renal failure. So even a vitamin can be dangerous if not used properly. இது எனக்கு ரொம்ப ஒரு பிடிச்ச ஸ்லைடு இது. So இந்த கடைசி பாயிண்ட் ரொம்ப முக்கியம். How dangerous a drug is dependent on the skill of the prescriber. So நீங்க மருந்துகள் எழுதும் பொழுது இந்த மருந்து தேவையா, என் குடும்பம் இங்கு எனக்கு முன்னாடி உட்கார்ந்தனா, is this the drug that I would use, and can we use the least number of drugs possible with multiple mechanisms of action that translates into excellent clinical benefit. And இது ஒரு முக்கியமான ஸ்லைடு இது. எனக்கு before 1962 the mortality was high in someone in a coronary care unit, and as years go by progress is better and better. The mortality has come down, but in the diabetes group blue la irukku idla cursor vela sey mattengudhu. But even with the most advanced treatment after 2000, still the mortality with someone with diabetes is double that compared to someone without diabetes. So it just tells something that having diabetes itself is not a great predictor of outcomes in a CC, even though advances have been made. And in the diabetes world, shake panna paper idu enakku adu varaikum we were thinking about a diabetes drug as just a glucose lowering drug. But in the New England Journal of Medicine 2007, again I would request all the attendees to have pen and paper in hand. சில முக்கியமான ட்ரையல்ஸ் பத்தி பேச போறேன். இதெல்லாம் எல்லாத்தையும் சொல்ல முடியாது, பட் நீங்க நோட் பண்ணிக்கோங்க. இந்த ரோசிக்ளிட்டசோன் and increased risk of myocardial infarction, whether true or not on தெரியல, but still a 42% relative increase in heart attacks if you use rosiglitazone. In the diabetes world, got to know that maybe these drugs can do something more than just glucose lowering, and appo the US FDA started to mandate cardiovascular outcome trials for those with diabetes. And again, இது எல்லாருமே ஒரு பேனா பேப்பர்ல எழுதிக்கோங்க. இது என்னோட golden lines. I think it's a very helpful 7 golden lines to remember when you're choosing a diabetes drug. The first question is, இந்த மருந்து நல்ல சர்க்கரை நோய் மருந்தா? இது சுகர் அளவை குறைக்குமா? Does it lower blood glucose? Number 2, is it weight neutral? இது அட்லீஸ்ட் வெயிட்டை குறைக்கலனாலும் பரவாயில்ல, வெயிட் நியூட்ரலா இருக்குமா? Number 3, does it cause less hypoglycemia? எனக்கு we now know that hypoglycemia is not about வெறும் சர்க்கரையை போட்டுட்டு பிஸ்கெட்டை சாப்பிடுறது கிடையாது. There's an increased risk of cardiovascular outcomes, increased risk of coronary death with severe hypoglycemia. Number 4, is it at least CV neutral? Even though it's not CV beneficial, it shouldn't be CV harmful. Number 5, in the மருந்து, is it cost effective? And cost, I'm not talking about மருந்தோட விலை 50 ரூபாயா இருக்கும், but it might reduce long-term risk of heart attacks and strokes, saving lakhs and lakhs of rupees from a hospital admission. So cost effectiveness in the long term and short term, rendume paakano. Is it easy to administer, and are there no long-term ill effects? Idhe meri oru marundu irukana satyama kediyadu. There's no single drug that would tick all the 7 boxes. So we have to look at every single box here and choose the right drug for your patient. And India வந்து நமக்கு ஒரு யூனிக் சேலஞ்சஸ் இருக்குது. வெள்ளக்கார நாடு மாதிரி கிடையாது. சும்மா இந்த செமாக்ளூடைடு, டியூலாக்ளூடைடு இன்சூரன்ஸ் கவர்லாம் இங்க கிடையாது. Every patient, most of them, 70% have to pay out of their pocket. So we are a completely different diabetic. We are a currency poor diabetic. We are a confused diabetic. எனக்கு இந்த 3 டாக்டர்கள் நம்ம ஊர்ல அதிகம். வாட்ஸ்அப் டாக்டர்கள், கூகுள் டாக்டர்கள், தீவிரவாதிகள் என்று சொல்லப்படும் சொந்தக்கார டாக்டர்கள். So நிறைய கன்ஃபியூஷன் வருது. We are very complication prone diabetic. We are completely under the mercy of the doctors treating the patient, and more type 1 diabetes ka sonna. So we'll just go through the good, bad and ugly. And ஒரு கேஸ் வச்சு நான் illustrate பண்ண போறேன். நீங்களும் அப்படியே யோசிங்க நான் கேஸ் போக போக. For example, this is a 61-year-old male who's a non-smoker, is a known diabetic for 5 years with a history of hypertension, but no history of coronary artery disease. So there's some guy with multiple risk factors for diabetes on metformin, 850 milligrams BD, the near maximal dose of metformin, and sarsunamide is on an ARB and a statin. BMI on the obese side, 31.2, with a suboptimally controlled diabetes, HbA1c of 9.5, fasting 148, 246, renal function is normal. இதான் உங்க பேஷண்ட்க்கு உங்களுக்கு முன்னாடி இருக்க ஒரு கிளினிக்ல. I'm just thinking loud as to what would be your thought process about getting the glucose under control. So the patient is already on metformin, uncontrolled, obese, diabetic patient with hypertension. normal renal function, and near maximal dose of metformin. And what would be your next drug of choice, which is both patient-friendly and purse-friendly. So first of all, metformin patti namak theriyanum. In the patient ku metformin da correct ana drug. Either a good, bad and ugly. Again, please have a pen and paper at hand. Sila mukkiyamaana tips solren nanu. Idella romba practical tips and you have to go and read about it. Metformin inhibits hepatic glucose production. So its main action is to reduce liver production of glucose. But romba mukkiyama, it acts through AMP kinase pathway. The AMP kinase pathway activate panni vittana, it reduces free fatty acids and reduces lipolysis. Another, we know that FFAs are main reason for insulin resistance. So idu koranjaduna insulin sensitivity improve agum, and metformin also improves intestinal absorption of glucose. And romba mukkiyama in the AMP kinase pathway activate பண்ணும்போது LKB1 or tumor suppressor gene activate பண்ணும். So there's a lot of research going on metformin and cancer reduction. So mechanism of action இத நீங்க தெரிஞ்சுக்கோங்க. How good is metformin in terms of cardiovascular outcomes, kidney and liver? Or a common misconception amongst practitioners, metformin kidney failure varum appadinu. It's the other way around. If you use metformin correctly, it is very safe for the heart, kidneys and liver. And UKPDS was a very long-running clinical trial with metformin, and it reduced cardiovascular outcomes. Cancer and metformin, talking points na appai sonna. Observational studies have shown a reduction in cancer, especially colorectal cancer, breast cancer, and all-cause cancer mortality with metformin. But randomized controlled trials have not. So there's a lot of work going on. But it's a nalla advantageous situation. For obese diabetic, metformin is always good because obese people are more prone for cancer. Weight, you might get a 0.5 to 1 kilogram weight loss with metformin or weight neutral and very low hyporisk. It doesn't stimulate the insulin. So in terms of the good points for metformin, a fantastic drug for cardiovascular outcomes, stroke, kidney, and there's some evidence that metformin is useful for fatty liver as well. It possibly reduces cancer. It's weight neutral and very low hyporisk. என்னென்ன பிரச்சனைகள் வரலாம் metforminல gastrointestinal side effects 5%ல வரலாம். So always start low and slow. மெதுவாக ஆரம்பிச்சு கொஞ்சமா கூட்டுங்க. And if the patient develops severe nausea or vomiting, you've got to stop the drug. If it's a very mild nausea, for 2 weeks, it's better. B12 deficiency metformin romba hype பண்றாங்க. நான் ரொம்ப பார்க்கிறது இல்ல. But in the rule ஞாபகம் வச்சுக்கோங்க, இதுவும் நோட் பண்ணிக்கோங்க நீங்க. The 30, 5 and 1 rule for B12 deficiency with metformin. அப்படின்னா என்ன சார் அர்த்தம்? 30% patientsக்கு there will be impaired absorption of B12. Only 5% will have low B12 deficiency on blood test, and less than 1% will have frank megaloblastic anemia on investigation. So maybe in the sattamathra போடுறதுக்கு இது ஒரு காரணமா இருக்கலாம், but just remember that the higher the dose, the more likely for this. And இன்னொன்னு the lactic acidosis, இது சத்தியமா நான் ஒரு கேஸ் கூட பார்த்ததில்லை. After 25 years of doing diabetes, I've seen 0 cases of lactic acidosis with metformin. So எப்ப யூஸ் பண்ணக்கூடாது, அகைன் பென் டு பேப்பர் அட் ஹேண்ட் இதை எழுதிக்கோங்க. எப்பவுமே வெறும் கிரியாட்டின் மட்டும் பார்க்காதீங்க. உங்க லேப்ஸ்ல EGF வர கால்குலேட் பண்ண சொல்லுங்க. இது glomerular filtration rate, இது ஒரு சின்ன ஆப் தான். இது லேப்ஸ் கேன் டூ இட். EGFR less than 30 ml per minute அப்படின்னா don't use metformin, stop it. 30 to 45 குள்ளர EGFR இருக்குன்னா you can use a maximum of up to 1 gram per day, and 45 க்கு மேல இருந்துச்சுன்னா you can use the 1.5 to 2 grams a day. And நிறைய பேஷண்ட்ஸ் metformin 3 grams வரைக்கும்லாம் யூஸ் பண்றாங்க. தயவு செஞ்சு ஹை டோசஸ்க்கு போகாதீங்க. Personally speaking, I don't increase the metformin dose more than 1.5 grams per day, and at the most 2 க்கு போங்க, அதுக்கு மேல வேண்டாம். So metformin பத்தி இதெல்லாம் நீங்க தெரிஞ்சுக்கணும். What are the absolute contraindications to metformin? EGFR less than 30 இருந்தா கொடுக்காதீங்க. And if the patient is decompensated, or a critical illness, or ICU patient, or a severe renal disease, septicemia, இதெல்லாம் இருந்துச்சுன்னா தயவு செஞ்சு ஸ்டாப் பண்ணுங்க. இங்கெல்லாம் தான் the lactic acidosis risk உங்களுக்கு வரும். And there's a lot of work going on metformin with lungs, neurodegeneration, reproduction, muscle, adipose tissue. இந்த மருந்து பத்தி நமக்கு நிறைய தெரிய மாட்டேங்குது, but we are learning a lot with metformin. So back to the case, this obese guy with hypertension and diabetes, would we agree with metformin being the first tablet that his doctor started? Absolutely yes, because it's a good drug. It causes around 1 to 1.5% HbA1c reduction as monotherapy. It is very good for the heart and the kidneys, and a very low risk of hypoglycemia. So we would agree with that. And it comes to closest to ticking all the boxes. It's lowers blood glucose, it's weight neutral, causes less hypoglycemia, lowers or at least be CV neutral, very cost effective, easy to administer. In terms of B12 deficiency or lactic acidosis, minimal da, so another tick panla, but it is the closest coming to that. Adutha drug, India common general practitioners use panadu sulfonylurea, especially glimepiride or glibenclamide. So sulfonylurea or scanner or microscope how good is the drug? It's an excellent glucose lowering drug. So the mean HbA1c reduction with sulfonylurea is 1 to 1.5%. It's very cheap, very widely available, and it's used for more than 50 years. In fact, metformin community sulfonylurea, so it's a known devil. And pen to paper, please go and read about Carolina trial. This is a multi-million-dollar trial done by linagliptin, comparing glimepiride. And in fact, they did the trial for glimepiride. In the trial, glimepiride is as safe as linagliptin in terms of cardiac outcomes. So there's been a lot of controversy as to CV safety of sulfonylureas. And in the Carolina trial puts to rest, at least to the fact that glimepiride seems to be cardio safe as similar to linagliptin. Enenla bad and ugly with sulfonylurea. Hypoglycemia is a major risk with sulfonylurea. Common doctors nenekirangana insulin la mattumda low glucose varum sulfonylurea la varadunnu. Glibenclamide is the worst agent when it comes to severe hypoglycemia. Another, please, friends, please take 30 seconds of your time. Any diabetes drug you start, நெஞ்சு படபடப்பு, கை கால் நடுக்கம், குப்புன்னு வியர்த்து கொட்டுதல், தலை சுத்தல், மயக்கம் வந்தா சுகர் குறையுதுங்க, உடனடியா சர்க்கரை ஏதாவது ஒண்ணு போட்டுணும்னு சொல்ல ஆரம்பிச்சிடுங்க. எனக்கு lot of patients, doctors, we did a survey on how much doctors talk about hypoglycemia to patient. 67% of doctors in the survey did not talk to patient about hypoglycemia. In fact, நிறைய patients night 1 மணி 2 மணிக்கு heart attack நினைச்சு pillar to post சுத்திட்டு இருக்காங்க, not knowing that they can take a simple teaspoon of sugar. So please educate patient about hypoglycemia, especially with sulfonylurea. And the longest acting is glibenclamide. So the most effective drug in terms of lowest hypopotential is gliclazide. So another most favorite drug is gliclazide, and it has got an intermediate half-life compared to glimepiride or glibenclamide. அடுத்தது CV safety வந்து glibenclamide கூட ஒரு question இருக்குது. Something called ischemic preconditioning, where அந்த collaterals develop ஆறது வந்து glibenclamide தடுக்கலாமோ அப்படிங்கிற ஒரு சந்தேகம் இருக்கு, because you've got sulfonylurea receptors in the heart called SUR2A receptors, and glibenclamide seems to have affinity with SUR2A, but this is not proven in human models. It's mainly in animal models. And again, UKPD study for 20 years, glibenclamide was used with no big evidence, but sila kelvigal irukku, and 2 to 4 kilogram weight gain with sulfonylureas. So again, this is a good review article on cardiovascular safety of sulfonylureas because it's controversial, but it's possible that SU-mediated inhibition of ischemic preconditioning irukkalam, or maybe the comparator drug is so good, like metformin or SGLT2, that sulfonylurea is showing bad outcomes. And hypoglycemia with sulfonylurea is a problem, and weight gain in the long term, can it increase the risk of cardiovascular disease? And again, hypoglycemia diabetes underestimate panna vendam, because we now know that hypoglycemia is only not about glucose, but increases exponentially the risk of major heart attacks and strokes. So in the patient ku adutha mathrai sulfonylurea va irukuma, does it lower blood glucose? Definitely nalla mathrai idu. Weight neutral irukuma, BMI 31 irukku. I don't think this is a great choice for that. Does it cause less hypoglycemia? Absolutely not. In fact, in terms of oral drugs, it has the maximum potential for hypoglycemia. Is it lowering or at least be CV neutral? I think with confidence you can say that gliclazide and glimepiride are cardio safe. And there's a question mark over glibenclamide. So if you're using it, I would probably not use glibenclamide. Is it cost effective? Very cost effective, very easy to administer. Are there no long-term ill effects? Again, risk of serious hypoglycemia in the long term is always there. So, aduthathu pioglitazone. Innuna nariya practitioners, I am seeing a lot of use of pioglitazone. There are a lot of doctors who vouch for pioglitazone. Personally, na indha mathrai ipo use pannadhu kedaiyadhu. I think there are better drugs to use than pioglitazone. Again, this is a very controversial area. So, arumiyana drug anakka. It seems to act on the problem of insulin resistance. So in the matra enna pannudhu appadina உங்களுக்கு வயிறுல இருக்கிற அந்த விசரல் ஃபேட்டை வந்து மெச்சூர் சப்கியூட்டேனியஸ் ஃபேட்டா கன்வெர்ட் பண்ணுது. ஸோ இட் ஆக்ட்ஸ் பை PPAR, gamma and alpha activation, which is paroxysmal proliferator activated receptor. And in the visceral fat is really bad because it secretes a lot of hormones that cause insulin resistance, especially TNF alpha, IL-6 இதெல்லாம். But once you change it to mature subcutaneous fat, it secretes a hormone called adiponectin, which reduces insulin resistance. So core concept of type 2 diabetes target பண்ணுதா? Definitely yes. So it's a great drug. How good is it as a glycemic lowering agent? Around 1% reduction in HbA1c. So it takes a longer time. ஆனா நீங்க பயோ ஆரம்பிச்சீங்கன்னா 6 வாரமான ஆகும் அந்த எஃபெக்ட் தெரியறதுக்கு, because it acts by gene transcription. அதனால ஒரு acute control பண்ணா sulfonylureas are much better than pioglitazone, but it's as good as metformin and sulfonylurea in the long term. இந்த CV benefit இது ரொம்ப கான்ட்ரோவர்ஷியல். நிறைய பேர் வந்து ரோசியும் பயோக்ளிட்டசோனும் ஒரே மாதிரி போடுவாங்க, ரெண்டும் டிஃப்ரெண்ட். Rosiglitazone, there is some concern about increased risk of MI, but pioglitazone seems to be CV beneficial. Again, pen to paper எடுத்துக்கோங்க. இந்த ட்ரையல்லாம் உங்களுக்கு தெரிஞ்சே ஆகணும். Proactive trial. So this is a trial where around 5,000 patients were started on pioglitazone, and it seems to cause good cardiovascular benefit compared to placebo. And the IRIS trial, where pioglitazone was used for patients with TIA or stroke, and also seemed to reduce the risk of recurrent stroke. Another, it seems to be okay, or at least modestly beneficial in terms of cardiovascular outcomes compared to rosiglitazone. Kandipa less hypos because it doesn't stimulate pancreatic beta cell, and it's one of the excellent drugs for beta cell protection. Enakku and the pancreas சுத்தி இருக்கிற fat எல்லாத்தையும் அது எடுத்துரும், so that insulin resistance comes down dramatically. And நிறைய பேர் pioglitazone patientலாம் HbA1c 6.5 இருக்கும் 10 வருஷமா. And பயோவை எடுத்தீங்கன்னா sugars 400-500 போக ஆரம்பிச்சிடும். So it causes good beta cell protection and it's very cheap. ஆனால் இந்த மாத்திரை மேல பல கவலைகள் இருக்கு. ஒண்ணு வந்து ஹார்ட் ஃபெயிலியர். அதாவது என்ன சார் சொல்றீங்க, ஒரு பக்கம் CV பெனிஃபிஷியல்ங்கிறீங்க, ஒரு பக்கம் ஹார்ட் ஃபெயிலியரை இன்க்ரீஸ் பண்ணுதுன்னா, the risk of heart failure is not because of bad effects on the heart for pioglitazone, because it promotes fluid retention. So there are PPAR gamma receptors present in the epithelium, and it can reabsorb sodium and water. So அதனால வந்து உங்களுக்கு வந்து water retention இருக்கும், and that can precipitate a heart failure in someone with a pre-existing LV dysfunction. So அதனால ரொம்ப cautious இருங்க. Someone with a poor LV function, please don't use pioglitazone. அடுத்தது fractures. I am still seeing pioglitazone used in 70 வயசு லேடிஸ்க்குலாம் pioglitazone போட வேண்டாம். எனக்கு there's definitely an increased risk of cancellous fractures, and there is some data emerging that it can increase the risk of hip fractures as well. Again, though the numbers are very minimal, please do not use pioglitazone in postmenopausal women or those with a pre-existing history of fractures. வேண்டாம். அடுத்தது bladder cancer. இது ஒரு பெரிய கவலையான விஷயம். எனக்கு பிரான்ஸ் and ஜெர்மனி have banned pioglitazone, and அது வந்து ஏன்னு கேட்க தோணுது. இப்ப நீங்க பப்மெட்ல போய் pioglitazone and bladder cancer போட்டா ஒரு 100 ஹிட் வரும், 50 வந்து doesn't cause bladder cancer வரும், 50 வந்து there's an association வரும். So the jury is out, we don't know, but generally speaking 28,000 milligrams cumulative dose of pioglitazone can slightly increase the risk of bladder cancer. அதனால if there are any pioglitazone users in this forum, at least நீங்க யூஸ் பண்ணீங்கன்னா 7.5 milligram தாண்டி யூஸ் பண்ணாதீங்க. எனக்கு நம்ம higher the dose யூஸ் பண்ண அந்த cumulative dose சீக்கிரம் வந்துரும். And in fact, and the company has kept aside $2.4 billion for the lawsuits relating to bladder cancer. And male rats வந்து Takeda have shown that pioglitazone increases bladder cancer in male rats. அதனால ஒரு சிக்னல் இருக்கு. And very interestingly, இது rosiglitazoneல ஒரு பேப்பர் கூட இல்ல bladder cancer. So there seems to be a differential effect like heart attack. Rosiglitazone heart attack increase பண்ணுதுங்கறான், but pioglitazone is beneficial. And pioglitazone bladder cancer பெரிய controversy இருக்கு, rosiglitazoneல இல்லை. ஓகேவா? So but இத ஞாபகம் வச்சுக்கோங்க. And if you are using pioglitazone, at least ask for a history of hematuria, history of any bladder problems, and please don't use it in those patients. Weight gain, கண்டிப்பா 2 to 6 kilogram weight gain இருக்கும் pioglitazoneல. அதுக்கு பல காரணங்கள். ஒன்னு வந்து it stimulates the appetite in the central nervous system. அதனால pioglitazone போடுற பேஷண்ட் எல்லாம் பாத்தீங்கன்னா நல்ல பசி எடுக்கும், நல்லா சாப்பிடுவாங்க. And ரெண்டு வந்து it changes the visceral to subcutaneous fat, which is more mature and weight இன்னும் அதிகமா இருக்கும். And finally, it causes fluid retention. So there are 3 reasons for weight gain with pioglitazone. And there are some case reports of macular edema with pioglitazone, fluid retention. And those with a history of severe, moderate to severe non-proliferative diabetic retinopathy or a history of macular edema, தயவு செஞ்சு pioglitazone use பண்ணாதீங்க. So, and இதெல்லாம் நிறைய papers, but in the patient pioglitazone use பண்ணுவேனா நான் என்னைய கேட்டுப்பேன், it definitely lowers blood glucose, கண்டிப்பா HbA1c 9.5 ல இருந்து ஒரு 8 க்கு கொண்டு வரும். இது weight neutral, ஏற்கனவே BMI 31 இருக்கு. இதுல we don't want another 3 to 4 kilogram weight gain. Number 3, does it cause less hypoglycemia? Definitely yes. Is it CV neutral? At least with pioglitazone, you can say that. If you're the worst critic of proactive trial, you can say it's CV neutral. But if you trust their work, it is CV beneficial. Is it cost effective? Yes. Is it easy to administer? Yes. But are there no long-term ill effects? Idu romba kavalai. So bladder CA, fractures, heart failure, macular edema, I think there are better drugs to use than pioglitazone enna porthorik. அடுத்தது gliptins. இது காமனா நம்ம யூஸ் பண்ற drug இது. Gliptins வந்து as a monotherapy, there are very weak drugs. ஆனா நீங்க gliptin monotherapy பாத்தீங்கன்னா 0.6 to 0.7% reduction in HbA1c. But when you add them on with metformin, around 1.2 to 1.5% reduction in HbA1c. So there are excellent additive drugs. And இது வந்து fire and forget drugs இது. So இதை போட்டோன்னா நமக்கு கொஞ்சம் side effect பத்தி மறந்துடலாம். எனக்கு the risk of hypoglycemia is extremely low and the safety profile is generally very smooth. And it has a unique action called glucose dependent insulinotropic action. அப்படின்னா என்ன அர்த்தம்? சர்க்கரை அளவு அதிகமா இருந்துச்சுன்னா இன்சுலின் செக்ரீட் பண்ண வைக்கும். சர்க்கரை அளவு நார்மல் ஆச்சுன்னா இது வந்து இன்சுலின் சுவிட்ச் ஆஃப் பண்ணும். So risk of hypo is very low. Cardiovascular safer, yes, with a few exceptions. நான் அதை பத்தி பேச போறேன். And in the drug trials they were touting it as a cardiac beneficial drug, but it was very disappointing. All the trial outcomes were CV neutral mostly, were renal safe generally and weight neutral. So நிறைய நல்லது இருக்கு இந்த மாத்திரையில. என்னெல்லாம் பிரச்சனைகள்? No CV benefit whatsoever, generally speaking. At least it's as good as placebo in terms of non-fatal MI, non-fatal stroke and cardiovascular death. Heart failure is a surprising finding with 2 drugs. Saxagliptin and alogliptin. அதனால நான் personally இந்த ரெண்டு drugs யூஸ் பண்ணதில்லை because sitagliptin, linagliptin does not show any increased risk of heart failure signal in either the TCOS trial or the Carmelina or Carolina trial. And again, no one can explain why heart failure with gliptins. And please, எல்லாரும் இதை நோட் பண்ணிக்கோங்க. I'm seeing a lot of skin reactions with vildagliptin as well. So in the pemphigoid, like bullous-like eruptions, angioedema, rashes, இதெல்லாம் வந்துச்சுன்னா பார்த்துக்கோங்க நீங்க. சில வில்டான இல்ல, gliptinsல ஜெனரலா வரலாம், vildagliptinல கொஞ்சம் more காமனா பார்க்கிறோம். Liver function test, again with vildagliptin, routine பண்ணுவோம். எப்படியும் diabetic patient நம்ம பண்ணுவோம். ரொம்ப rare, but just keep an eye on it. And most controversial thing is pancreatitis and pancreatic cancer. So the US FDA has said at this point of time that there is no tangible evidence linking gliptins and pancreatitis. But நீங்க என்ன ஞாபகம் வச்சுக்கணும்னா, இந்த Gila monsterன்னு ஒரு lizard இருந்தது. அதுல இருந்தா இந்த gliptins கண்டுபிடிச்சாங்க, DPP4. But a lot of those patients presenting to emergency with the Gila monster bite had pancreatitis. So இந்த மருந்து pancreas ஏதாவது பண்ணுமோங்கிற கவலை இருக்கு. அதனால anyone with a history of severe gallstone disease, a previous history of pancreatitis, or acute alcohol excess, severe hypertriglyceridemia. So in the pancreatitis risk factor இருக்கிற பேஷண்ட்க்கு தயவு செஞ்சு யூஸ் பண்ணாதீங்க. And anyone presenting with severe acute abdominal pain on a gliptin, think about pancreatitis. And அப்படி இருந்தா ஸ்டாப் பண்ணுங்க. And எல்லாரும் கொஞ்சம் பென் அண்ட் பேப்பர், இதெல்லாம் முக்கியமான பாயிண்ட் நோட் பண்ணிக்கோங்க. எனக்கு இந்த ஜாயிண்ட் பெயின் வந்து இட்ஸ் a black box warning now. And I've personally seen a few patients with severe rheumatoid arthritis-like pain around 5 days to 5 months after starting therapy. அப்படியே பார்த்தா RA மாதிரியே இருக்கும். And எல்லா blood testum negative இருக்கும். And once you stop the gliptin, it becomes better. So if you find unexplained severe polyarthritis on gliptins, just please think about joint pain related to gliptins. And there is one study from Japan, UK one terla, linking a slightly increased risk of inflammatory bowel disease with gliptins. இதெல்லாம் common கிடையாது, extremely rare, but I think you've got to be aware of these things. So இது TCOS trial உங்களுக்கு எல்லாருக்கும் தெரியும். So pen and paper, இதெல்லாம் landmark clinical trials that you should be reading. Trial evaluating cardiovascular outcomes with sitagliptin, No difference in terms of cardiovascular outcomes compared to placebo. So drug company every in the disappointing result spin panana, we are at least cardiovascular safe spin panna. And saxagliptin it was a very surprising outcome. So in the patient gliptins careful patients with a prior history of heart failure, please don't use saxagliptin. Patients with a chronic renal impairment or CKD 3-4 please don't use saxagliptin. In the rende and this Q4 of BNP, highly elevated BNP levels patient don't use it. So screen sharing poichu sir. Sir, screen sharing
Dr. Sendil.
Rashikar sir, screen sharing sudden stoppage.
That's what I did.
Yes, sir. So just a minute, sir. We are just
Yeah,
checking, sir.
please.
Doesn't matter, Krishna. We can go ahead till they receive the
yes,
screen.
sir. Kindly proceed, sir.
No, sir, just 1 minute, 2 minutes.
Okay. So, in terms of this drug, obese patient, type 2 diabetes, CAD, gliptin seems a reasonable choice. You can use any of the gliptins that you want, but cardiovascular extra beneficial the answer is no at this point of time. Adutha drug.
Sir, it's done, sir.
Thank you. Screen visible?
Yeah. Yes.
Yes, sir. Yes,
Yeah,
sir.
it is visible.
It's moving. Everything.
Okay. So, in terms of gliptins for this patient, it's a very modest drug, but when you come in with metformin, it works. It's weight neutral, less hypo, CV neutral, cost effective, easy to administer. Gliptins no long-term ill effects, sir. We can't say confidently with all these pancreatitis thing looming. Alpha glucosidase inhibitors, நம்ம ஊர்ல ரொம்ப favorite drug, Voglibose, Acarbose. Sorry, நான் ரொம்ப இத பத்தி பேசுறது இல்ல. எனக்கு நான் ரொம்ப இத யூஸ் பண்ணது கிடையாது. It is thought that India மாதிரி ஒரு countryக்கு where postprandial rise is targeted and beneficial in Indian population. And இதோட நிறைய proponents இந்த trial சொல்வாங்க. Again, please take pen to paper at hand and make a note of this trial. In the trial பேர் stop NIDM trial. இது pre-diabetes patient Acarbose கொடுத்தா 49% relative risk reduction heart attack இத நம்பவே முடியல இது. And there are a lot of methodological flaws with the study, and you can't believe that glucose drug with a HbA1c lowering of around 0.4% can reduce heart attacks by around 49%. Another, in the number, main disadvantages in GI side effects, especially when you combine with metformin, naria flatulence, diarrhea, and the A study, Acarbose in cardiovascular evaluation study, the Chinese study on around 7,000 patients. It did not show any cardiovascular advantages compared to a placebo. So, this is jury's out. அடுத்தது SGLT2. இது இப்ப left, right and center use பண்ணிட்டு இருக்கும் number. 3 trial எல்லாருக்குமே தெரிஞ்சிருக்கணும். ஒன்னு EMPA-REG outcome trial. இது empagliflozin. அடுத்தது CANVAS trial. இது canagliflozin. And the DECLARE-TIMI trial with dapagliflozin. And நிறைய பேர் என்ன பண்ணுவாங்கன்னா இந்த trial to trial compare பண்ணுவாங்க. இது better அது betterன்னு. It is comparing apples and oranges. ஏன்னா நீங்க என்ன பார்க்கணும்னா EMPA-REG trialல nearly 100% of patients had established cardiovascular disease. CANVASல only 65% had established cardiovascular disease, and DECLARE-TIMIல only 40% had cardiovascular disease. அதவங்கலாம் they had multiple risk factors like the patient that we are seeing. அதனால ரொம்ப cautious-ஆ இருக்கணும் இந்த trials interpret பண்ணும்போது. But EMPA-REG என்ன சொல்லிச்சுன்னா, if the patient has got a pre-existing cardiovascular disease and you give empagliflozin on top of standard treatment compared to placebo, there's around a 35% reduction in hospitalization for heart failure and 32% reduction in all-cause mortality. So this is just some really good results in someone with a pre-existing ASCVD. Dapagliflozin, again, only 40% had pre-existing ASCVD. There was a big reduction in hospitalization for heart failure. And நிறைய mechanisms இருக்கு. இதெல்லாம் நீங்க படிக்கணும். So it seems to do a lot of beneficial effects with heart, kidney, vasculature, and whole body, thereby reducing the risk of heart failure in a big way. So please read all these trials. You've got DAPA-HF trial, DAPA-CKD trial, and EMPEROR reduced with empagliflozin. Again, very importantly, even in the absence of diabetes, it seems to be efficacious in reducing risk of heart failure. So a lot of cardiologists are using SGLT2 even in those without diabetes and reduced LV function. So what are the good, bad, and ugly with SGLT2? I think in terms of beneficial CV effects, this is a great drug. At the minimum, you can say that in someone without a pre-existing ASCVD, it seems to reduce hospitalization for heart failure. And we know that heart failure comes with its own set of morbidity and mortality. In someone with a pre-existing ASCVD, it seems to reduce cardiovascular deaths and all-cause mortality. This is for SGLT2 in terms of CV effects. Definite reduction in HHF for those with or without ASCVD, and a lot of accumulating evidence with renal effects. So Credence trial irukku, DAPA CKD irukku. So it's a NCD drug na solva. It's a nephro, cardio, and diabetes drug. And it causes around 3 kilogram weight loss. But diabetes injury in the SGLT2 prescribe we are seeing a lot of complications related to unscrupulous prescribing of SGLT2. Women 10% develop vulvovaginal candidiasis or vaginal infections or urinary tract infections. So in the மருந்து கொடுக்கும் பொழுது தயவு செஞ்சு கவுன்சில் பண்ணுங்க. யூரின் போகும்போது எரிச்சல் நமைச்சல் வந்தாலோ அல்லது யூரின் போற இடத்துல எரிச்சல் நமைச்சல் வந்தாலோ இந்த மாத்திரை நிறுத்திட்டு எங்களுக்கு சொல்லிடுங்க. எனக்கு if the patient goes into developing pyelonephritis, it can be devastating. I've seen quite a few bad pyelonephritis with the SGLT2 inhibitors where the patient was not counseled about this risk. அதனால தயவு செஞ்சு இதை பார்த்துக்கோங்க. ஒரு mild candidiasisனா அதை ட்ரீட் பண்ணி கண்டினியூ பண்ணலாம், பட் ரிகரண்டா வந்தா நிறுத்துருங்க. Male patientsல ரொம்ப நான் இதை பார்க்கறது இல்லை. Female patientsல around 10% is what it's quoted. அடுத்தது very elderly patients when you're prescribing SGLT2, beware of hypertension, acute kidney injury. ஏற்கனவே patients சார் சொல்ற மாதிரி ACE inhibitor, ARB, thiazide இருப்பான். இது கூட you're adding a drug which causes intravascular volume depletion, and just be very cautious. Though it's safe for the kidneys, in the wrong patient, it can precipitate acute kidney failure. அடுத்தது euglycemic DKA. அப்படின்னா என்னன்னா glucose will be less than 250 or 200, but the patient will be in severe ketoacidosis. So இது இதே மாதிரி நீங்க பாத்தீங்கன்னா immediate SGLT2 stop பண்ணிடணும். And நிறைய பேர் அதையே கன்டினியூ பண்ணிட்டு deaths have been reported by continuing SGLT2 inhibitor in someone with ketoacidosis. So எதனால இது வருது? யூரின் வழியா glucose வெளியேறதுனால the body is getting worried because there's a lot of energy through urine. அதனால it converts the fat into ketone bodies as a backup energy source. So small amount of ketone bodies like beta hydroxybutyrate is very beneficial for the heart. In fact, another heart failure better than நினைக்கிறாங்க. But ஒரு critical illness ஒரு infection பொழுது சடனா இது அதிகமாயிடுச்சுன்னா patient ketoacidosல இருப்பான், but glucose நார்மலா இருக்கும். So please be aware of it. With canagliflozin, there are two particular things that have come out in trials. One is foot amputations. It seems that there's a doubling of risk of foot amputations with canagliflozin in Canvas trial. எதனால வருது யாருக்கும் தெரியல. It is possible that there is around 7% volume dehydration because of diuretic effect of SGLT2. அதனால peripheral vascular disease இருக்கிறவங்களுக்கு இது இன்னும் lower extremity blood flow கம்மி பண்ணுதா possible, but a lot of meta-analysis have not proven that canagliflozin is associated with foot amputations. But be cautious. At least one trial la idu solran. So please don't use SGLT2 inhibitors with the history of severe peripheral vascular disease, previous history of foot ulcers. Romba cautious arunga. Bone fractures, again, elderly patients, there's a big risk of postural hypotension. So another falls for the fracture varla, but there's some evidence that canagliflozin seems to alter the bone structure as well. And Fournier's gangrene, again, the black label warning. So perineal abscess, idella use pannadinga. Cost line kammi aichu. So in the patient ku povuma kandipa, it lowers blood glucose, it's weight beneficial, less hypo, it is CV beneficial, cost effective, easy to administer, but beware of the side effects that we talk. Sir, nearly done, 2 minutes, sir. அடுத்தது oral semaglutide. கொஞ்சம் இதை நோட் பண்ணிக்கிறீங்களா? இது rivalsisங்கிற பேர்ல வருது. இது Pioneer 6 trial, and it showed non-inferiority in terms of cardiovascular outcomes. It's the first available oral GLP-1 analog in worldwide and in India at this point of time. So in the மாதிரி பத்தி patients கேட்கலாம், உங்களை கூகுள்ல படிச்சுட்டு தெரிஞ்சுக்கோங்க. And a lot of work going on with oral semaglutide in terms of obesity, type 2, ASCVD, CKD, dyslipidemia, non-alcoholic steatohepatitis, and even Alzheimer's dementia as well. There's some good studies going on reducing Alzheimer's dementia. Matra இது வந்து 3 milligram, 7 milligram and 14 milligramல வருது இந்த மாத்திரை. ஃபர்ஸ்ட் 1 monthக்கு 3 milligramல ஸ்டார்ட் பண்ணோம். இது ஆரம்பிக்கும் பொழுது கிளிப்டின்ஸ் இருந்தா ஸ்டாப் பண்ணிடணும் நீங்க. எனக்கு இது ஒரே குரூப் ஆஃப் ட்ரக். நாசியா வரலாம். அதுக்கப்புறம் டாலரேட் பண்ண 7 milligramக்கு போங்க. 5 kilogram weight loss பார்க்கணும். 5 to 6 kilogram weight loss on oral semaglutide. So it's very good that way. And work is going on, pure trial நினைக்கிறேன் for cardiovascular superiority. But we can safely say that it's beneficial for the heart and doesn't cause any major problems. And there is accumulating evidence that it's renal and CV beneficial. இந்த மாத்திரையோட விலையை கேட்டால் தான் ஹார்ட் அட்டாக் வரும். ஒரு மாத்திரையோட விலை 310 ரூபாய் 3 milligram டேப்லெட், 350 ரூபாய் 7 milligramமும், 380 ரூபாய் 14 milligramமும். அதனால தான் பேஷண்ட் சொல்லுவாங்க, சார் என்ன மாரடைப்பு வரும்னு குறையும்னு சொல்றீங்க, மாத்திரை விலையை கேட்டால் எனக்கு இப்பவே வந்துடும் சார் உங்க கிளினிக் விட்டு போறதுக்குன்னு. ஸோ ஆல்வேஸ் கவுன்சில் யுவர் பேஷண்ட் அபவுட் த காஸ்ட் ஆஃப் த ட்ரக். நாசியா, ஜே, அகைன் pancreatitis இருந்துச்சுன்னா பண்ணாதீங்க. And there is some link between medullary carcinoma of thyroid and Rodel models in terms of GLP-1 analogs. So any family history of thyroid cancer or any history of thyroid surgery, please don't use the drug. So in the case முடிக்கிறதுக்காக, so obese individual on metformin with no renal problem or no cardiac problem, my personal opinion after metformin would be a SGLT2 inhibitor, preferably dapagliflozin. எனக்கு இது multiple risk factorsல the best evidence comes with the declared trial. And if பணம் பர்சு ஸ்ட்ராங்கா இருந்துச்சுன்னா we can counsel oral semaglutide. எனக்கு 5 kilogram weight loss இருக்கும். And இது ரெண்டும் வேணாம், urinary infection இருக்கு, bladder problems இருக்கு, பணத்தால் முடியலன்னா then DPP4 inhibitor would be the next choice. And last choices would be sulfonylurea, pioglitazone or AGA. பட் இது எதுக்கு சொல்றேன்னா, ஒவ்வொரு பேஷண்ட் நமக்கு முன்னாடி இருக்கும் பொழுது ஒவ்வொருத்தரோட ப்ராப்ளம்ஸ் என்னங்கிறத பார்க்கணும். இப்போ இதே பேஷண்ட் ஹிஸ்டரி ஆஃப் CABG, CAD இருந்துச்சுன்னா I would offer empagliflozin instead of DAPA because the best evidence for pre-existing ASCVD comes from empagliflozin, and there's evidence that GLP-1 analogs from REVAN trial dulaglutide seems to reduce cardiovascular outcomes. Whereas if ஒரு CKD4/5 இருக்கு இந்த பேஷண்ட்க்குன்னா ஒரு metformin plus linagliptin or metformin with insulinக்கு போயிடுவேன். Whereas இது ஒரு heart failure இருக்கு அப்படின்னா empower DAPAக்கு போகலாம். So I just want to finish my talk by saying that time to move away from just glucose centricity and think holistically about your patient. இவரோட வெயிட் என்ன, எந்த ஊர்ல இருந்து வர்றாரு, வீட்டின் நிலவரம் என்ன, பணமால் எப்படி இருக்காரு, ஹார்ட் ஃபெயிலியர் இருக்கா, கிட்னி ஃபெயிலியர் இருக்கா, இது எல்லாத்தையும் அசஸ் பண்ணிட்டு ஃபர்ஸ்ட் திங் இஸ் டு டூ நோ ஹார்ம். நம்மளால எந்த கெடுதலும் வரக்கூடாது. Then you decide on the best choice of drug. Individualized treatment on the 7 golden lines that I told you. Remember the pros and cons of each drug. Explain to your patient என்னெல்லாம் side effects வரலாங்கிறதையும் சொல்லிடுங்க நீங்க, so that it's not a surprise to them. And finally, கண்ணால் காண்பதும் போய், காதால் கேட்பதும் போய், கண்டு அறிவதே மை. அதான் KKP KAMனு போட்டிருக்கேன். ஸோ நான் சொன்ன ஸ்டடீஸ்லாம் நீங்களே படிச்சு நீங்களே you come to a conclusion based on it. And மாமியார்கள் என்னை திட்ட வேண்டாம். Every marriage has its mother-in-law, good, bad and ugly. Thank you very much.
Thank you, sir, for a nice lecture.
Okay, now Rajshekhar, any question in the chat box? You can fire those questions.
Only,
Rajshekhar?
yeah, just I'm checking, sir. All only register number. Dr. Krishnan Swaminathan, you have highlighted pioglitazone, rosiglitazone. What about a recent drug, lobeglitazone, and another drug, imiglitazone? Just a word about.
எனக்கு ரொம்ப அந்த கிளிட்டசோன் பத்தி தெரியல சார். பட் எனக்கு ரொம்ப தெரியல. மார்க்கெட்ல வரல இல்ல சார் அது?
Yes, it has come.
அப்படியே சார்
எனக்கு released it.
நீங்க சொல்லுங்க.
It is not that much everything. What about imiglitazone?
சார் அது என்னமோ மைட்டோகாண்ட்ரியல் ஆக்ஷன் சொல்றாங்க. when you ask for the literature, they have no trials to say that it reduces hard endpoints, sir. எனக்கு என்னமோ நம்ம ஸ்ட்ராங்கா இந்த மாதிரி மருந்துகள்லாம் அவசரப்பட்டு யூஸ் பண்ணக்கூடாது. 18 ரூபாய் 20 ரூபாய்க்கு
எக்ஸாக்ட்லி
வாட் டஸ் இட் டூனா சும்மா மைட்டோகாண்ட்ரியா அப்படி இப்படின்னு இந்த சாஃப்ட் எண்ட் பாயிண்ட் சொல்றாங்க. ஐ டோன்ட் யூஸ் இட் சார்.
இட் ஷுட் நாட் பை டு தி பர்ஸ் ஆஃப் தி பேஷண்ட்.
ஆமா கண்டிப்பா சார். அதுக்கு ஒரு ஸ்டாட்டினை போடலாம் 3 ரூபாய்க்கு, அதை நம்ம போட மாட்டோம்.
எக்ஸாக்ட்லி. அண்ட் வாட் அபவுட் That is, just remember G. I used to tell the mnemonic, just a letter G. You include all the drugs of anti-diabetic drugs. We have released 4 editions of my mnemonics medicine. 5th edition is underway. G, as you rightly pointed out, the glibenclamide, the most potent sulfonylurea, which has got a long half-life, but doubtful in ischemic preconditioning. It rather unravels ischemic preconditioning. Next is our glipizide. Next is glycoside, your favorite drug. And last but not least is glimepiride, which helps in ischemic preconditioning. Another non-sulfonylurea. What about your opinion? Glinides. That is, skip the meal, skip the dose. That is ripaglinide and natiglinide. That these 2 drugs. Another, yeah, please tell.
Repaglinide is very useful in those with renal impairment,
yes,
and where you're targeting postprandial rise, but it's very costly sulfonylurea, sir.
Okay. Next, you have told the glucosidase inhibitors. That is G, alpha glucosidase inhibitors. Again, it is good for postprandial hyperglycemia. Next G, that is glinides, that is metformin. I have had only 1 case of lactic acidosis in this 42 years of experience. That is guanides, metformin. Another G is glitazone, that is pioglitazone, no resiglitazone. Next, lobeglitazone. Another G is our gliptins, that is our starting from vildagliptin, sitagliptin. And yesterday also we discussed in City Physician WhatsApp forum about this pemphigus vulgaris case report. We discussed very highlights. And another G, that is our latest, that is SGLT2 inhibitors, gliflozin, that is sodium glucose transportase inhibitors. That is another thing is we have to be careful about the occurrence of ketosis. What's your experience of the non-diabetic ketoacidosis, especially in SGLT2 inhibitors? It aggravates.
I've not seen one single case, sir, but if you're using it cautiously, it shouldn't happen. So before any major surgeries, 3 days before, stop the drug and stop it in any acute conditions.
Genitourinary infections also we have to be careful. See, what about your experience of this galactation suppression, that is glucose suppression, that is our D2 dopaminergic agonist, though we don't use nowadays bromocriptine, D2 dopaminergic agonist.
Rumba weak drugs, sir. I don't think they have done anything great, and evidence is also lacking. Whatever trial, either positive CV benefit, but otherwise it was very similar to the stop-nedim trial. So I don't think we are using it, sir.
Another this glucose suppression, our hydroxychloroquine, which is helpful in polyarthritis, used to do in polyarthritis with diabetes. What's your experience of HCQ?
Zero experience, sir. Again, அது ரொம்ப பெரிய ப்ரொபஷனா வந்தாங்க உள்ளர வரும்பொழுது இது வந்து ஒரு peripheral players னு தோணுது, sir.
Almost only one pharma is putting, other pharma have withdrawn. So if you remember G, it includes all OHs, and your semaglutide, it will not it will almost remove the person packet, cuts the packet of the patient. So patients are very much afraid.
Yeah,
that we have to be very careful before we prescribe.
Yes, sir. Agreed.
Yeah, that is very important.
நிறைய questions வந்துட்டு இருக்கு, sir.
Sir, occasions BP uncontrolled, what is the drug of choice? Sir, Muruganathan, sir, not on.
Yeah, please, Rajir.
That is occasions BP uncontrolled. What is the drug of choice, but not on regular rise of BP? Intermittent control, uncontrolled.
Uncontrolled hypertension?
Yeah. Occasions BP uncontrolled. What is the drug of choice? Not on regular. Yeah.
No, the question itself is not very clear, but anyway.
It is very much confusing.
But you know what he means is somebody is on hypertensive drug. Sometimes the control is being lost, occasions. That's what he means, I think.
Okay.
So that is, see, first and foremost, as I said, you should see the control 24 hours. When somebody comes with BP in the morning, normal. Evening, it may be abnormal. And sometimes any emotion, any risk factors that may increase the blood pressure. So these are all only transitional.
Yeah.
If the blood pressure is under control, there will be no hypertension mediated organ damage. You see a BP normal and the patient has got eye changes or microalbuminuria, that means this patient has got uncontrolled hypertension. For that only, we should do at least once 24 hours BP monitoring, ambulatory BP monitoring, to see whether the blood pressure is normal throughout the day. Because what he says may be a nocturnal hypertension or BP variability. When BP variability is there, it is a problem. It is worse than the uncontrolled BP. When somebody has got 120/80 in the morning and has got 140/90 in the afternoon, and then 180/110 in the night, this is the patient who will develop cerebrovascular problem. So BP variability fluctuation is more harmful than the continuous BP. That is why you have to select a drug which controls BP variability, which is calcium channel blocker or a diuretic. So ACE or ARB or beta blocker will increase the BP variability, for which we should monitor the BP regularly and see what time the BP area goes, whether it is a nocturnal hypertension, whether it is a masked hypertension, whether it is a white coat hypertension, and whether they have got any associated hypertension mediated organ damage in the form of left ventricular hypertrophy or microalbuminuria or eye changes.
Yeah. That is why the dipping, nocturnal dipping, there are 4 types as Sir has told. That is normal dipping and extreme dipping, reverse dipping, no dipping. So the problem is extreme dipping is also very problematic, and also reverse dipping also problematic. Extreme dipping, patients go in for stroke, and reverse dipping, instead of dipping of blood pressure, there will be rise of blood pressure. So the patients will go in for heart failure. There are also 3 types of hypertrophy associated with hypertension. One is inappropriate hypertrophy, appropriate hypertrophy, inadequate hypertrophy. Inappropriate hypertrophy is with low volume stress. Appropriate hypertrophy is with normal wall stress. Inadequate hypertrophy with high wall stress. Inappropriate is very dangerous, asymmetric septal hypertrophy and all. This is the classification by Cruikshank, Authority of Hypertension. Sir, is aspirin required along with antihypertensive?
No, aspirin role for primary prevention is not there. Only in secondary prevention we use aspirin, and for hypertensive we need not give aspirin. Only in a pregnancy eclampsia we give aspirin. Otherwise, for a primary hypertension we don't give aspirin unless there is a secondary prevention possibility. We don't give aspirin.
So what about tenipride, Dr. Kishan Swaminathan?
Yeah, tenipride. Oh, sorry, Swaminathan, you go ahead.
Tenligliptin சொல்றாங்களா சார்?
ஆமா, tenligliptin.
Tenligliptin, they are telling me.
அதாவது tenligliptin நான் personally யூஸ் பண்ணது இல்ல. ஒன்னு வந்து cardiovascular outcome trials are not there, and in animal models வந்து it seemed to prolong QTc interval at high doses. அதனால all diabetic patients have got high cardiovascular risk. So the absence of a major CV outcome trial with tenligliptin அதனால நான் யூஸ் பண்ணது இல்ல சார்.
But we use tenligliptin very much because it's very cheap also. What about vildagliptin?
Vildagliptin வந்து cardiovascular.
Yeah, already you have highlighted very well.
There's no CVOT, but a lot of meta-analysis saying it seems to be safe.
Pemphigus, you are told the skin problem, allergic problem. And another sleep apnea and diabetics mellitus treatment of obesity and obstructive sleep apnea, control of comorbid condition.
In terms of drugs, there is one study where empagliflozin seems to reduce the risk of obstructive sleep apnea. Whether it's weight loss nalia or the transthoracic pressure gradients, but if there's one drug that can do it, empag is some evidence, but weight loss helps. It doesn't matter.
PCOD versus metformin.
It's a very controversial area. Don't give metformin for hirsutism. It has no effect. So if the patient has got anovulatory cycles, metformin seems to improve that.
But there are a lot of studies, Swaminathan, they use metformin for PCOS.
Other than in the setting of impaired glucose tolerance, sir, or in the setting of anovulatory cycles. But நிறைய பேர் சும்மா hirsutism இருக்கும், அதுக்கு metformin கொடுத்தா கேட்காது, sir.
They will even use spironolactone, it will increase hirsutism. And a few words about candidates who should be started on insulin therapy and regimen to start with. So he wants a preferential.
Other in terms of type 2 diabetes, the indications for insulin first step is a fasting more than 200, random more than 300, HbA1c more than 10%, osmotic symptoms and weight loss. In the அஞ்சு இருந்தா தயவு செஞ்சு இன்சுலினை ஃபர்ஸ்ட் ஆரம்பிச்சிடுங்க. எனக்கு ஒரு 1 month insulin போட்டு then you can change it to oral agents. In those
Swaminathan, you can add also pregnancy.
Pregnancy
and also any acute infection.
Any inpatients, definitely. And patients on oral agents, if the HbA1c is more than 8.5%, on 3 to 4 agents on maximal dose, that's the time for it.
What about pregnancy, gestational diabetes, PCOD, metformin? Will you advise or not?
The landmark clinical trial for metformin and gestational diabetes was the MIG trial, 2007. So it seems to be safe according to this trial. It's a controversial area, but naanga heavier use pandrom. Nice guidelines recommend metformin use. But doubt irundha insulin ku poita better. If the patient is not happy or if your obstetrician is not happy, use insulin.
A few words.
But actually, Swaminathan, in some other trials they say metformin is better than insulin.
BMJ meta-analysis metformin seems to be better than insulin on certain neonatal outcomes, but overall it seems to be the same, sir. But a controversial area, we use it heavily.
But we are also using, but no problem.
But DCI says okay. What is the role of metformin in prevention?
Prevention of in terms of diabetes. The landmark trial, DPP trial, lifestyle was much superior to metformin, sir. 15% reduction in lifestyle compared to 31% with metformin. So mudinja panato abilla metformin photo.
A few words about candidates who should be started on insulin therapy and regimen to start with. A few points with the diet management and insulin administration for type 1 diabetes.
ஐயோ அது ஒரு பெரிய டாக் சார். அது தனியா ஒரு 2 மணி நேரம் போடணும். அது விட்டுடலாம் நம்ம.
ஓகே. So already you told, sorry, is aspirin really required along with antihypertensive as long-term prevention of CAD? Sir has already told. Will any hypertensive cause gum hypertrophy? And if the hypertensive is stopped with the gum hypertrophy, reverse.
Actually, some of the drugs can cause gum hypertrophy, antihypertensive drugs. It can be even amlodipine can cause gum hypertrophy. ACE inhibitors can cause gum hypertrophy. And even, it may be a coincidence factor with some dental problems. See, I had a patient who had a gum hypertrophy. We saw he was taking some other drug. It's not due to antihypertensive. So you will have to have the history, whether it is dental hygiene or whether it is any other drug or the antihypertensive drug which causes gum hypertrophy.
Even perverted nasal smell, especially nifedipine. The patients who are going to pillar to post, at last they came to us and we found out it was due to nifedipine. We stopped and changed to some other drug. The patient has become completely all right. So we must know what are the side effects and toxic effect of the drugs. Very, very important. Apart from the potency and the efficacy of the drug, we must know the adverse effects also. So digital blood pressure monitors, are they reliable? Many times.
They are very, very, very reliable. Now we got a very, very standard BP monitors, cheaper available. In those days, we have to go for the website of the British Hypertension Society, International Hypertension Society. Now, even the Indian making BP monitors are very good. Recently, we requested ICMR to give the standard BP monitors which can be used easily throughout the country. So those days we say digital monitor means not correct. Now many digital monitors, almost like a mercury monitor, so we can definitely use. I saw one more question, Rajshekhar.
In my practice, I have seen so many female patients having low BP, 100/60. Is there any need of treatment or only when they have symptoms?
Actually, this is a very controversial subject. Now we have seen people below 120/80, they have a quite good life. And recently one article came, even 120/80 may not be safe. Reducing to 120/80 is good. That was one of the articles written by Venkatesh Ram. So if they can tolerate 180, nothing like that, they will be very happy. In fact, my friend cardiologist Geeta, he always say her BP is only 90/70 and she is very safe. And if she develops more than 110, it is hypertension for her, because from the beginning she got only 90/70. If there is no symptom, there is no signs of giddiness or partial hypertension, I think we need not treat.
Another thing is he has put tenligliptin, not tenligliptin and metformin, sustained release. Dr. Yeah, we are using, it is also equally good like other gliptins. The exact dosage schedule of Oglibos, Acarbose, either BD or TDS, according to the blood sugar level. That's all.
One more thing, Krishna. The Oglibos, etc., they claim microbiota change happens with Oglibos, and that is good also.
Provided the patient should not develop flatulence and dyspepsia, it should not be prescribed to patients with dyspeptic symptoms, irritable bowel syndrome. We must select the patient and accordingly we must prescribe. That is more vital.
I saw two questions, Rajshekhar. One was about the pregnancy hypertension drugs.
Yeah.
The pregnancy hypertension drugs, we always select only 3 drugs: labetalol, then alpha-methyl-dopa, and nifedipine, or calcium channel blocker.
So, and another thing is beta-labetalol.
Yeah, that's all. I said labetalol only. Labetalol, alpha-methyl-dopa, and then nifedipine. So these are the drugs. Now we don't use alpha-methyl-dopa like earlier. We start with labetalol only. Labetalol is very good drug. It's both alpha and beta blocker. It's good. And then nifedipine.
Calcium channel blockers we use, sir.
Yeah, calcium channel blocker. One word of caution: don't give nifedipine sublingually. Only orally we can give, not sublingually.
Rebound hypertension. We don't use, sir. No.
Yeah, that is one thing.
Not available.
Yeah.
One more question is contraindicated. Very important.
Yeah. One more condition I saw. One more question I saw. Hypotension. Is there any treatment for hypotension? See, when somebody has got hypotension, you must rule out any organic cause for hypotension. He may have any myocardial ischemia or problems with fluids. So if you rule out all the organic causes, and if somebody has got hypotension, you must assess completely, and then there is no such treatment for hypotension unless you rule out the other causes and then treat the cause for hypotension. Sometimes some people normally has less blood pressure, and they always fall when they stand for long, and you advise them the lifestyle modification, ask them not to stand, especially above the height tower and in the well, etc. You should be very cautious.
Orthostatic hypertension also we must keep it in mind.
Yes.
Another hypertension, the elderly postprandial hypertension. That is, whenever we take food, the patients may develop hypertension, especially in the elders, due to adrenergic stimulation. That also we have to keep it in mind.
According to definition, postprandial hypertension can happen even after 2 hours of food also, especially the elderly people.
Sorry, the
best thing is postprandial hypertension. They should take 500 ml of water. That will solve the postprandial hypertension.
Yeah, 500 ml of water.
So, sir, before we go in questions, and the fibrocalcific pancreatic diabetes are gliptin safe. Please don't use gliptins in those with fibrocalcific pancreatic diabetes. Which OHA is safe for lactating mothers? At this point of time, metformin has some evidence that the milk concentrations are extremely low, where in the OHA, it's either metformin or insulin.
Dr. Krishnan Samna, glipizide versus glycoside. Glipizide is the cheapest drug, all available in government hospitals.
Potency wise, glycoside is much better, sir, especially modified release glycoside. Glipizide yarku use pannumna very elderly or those with renal impairment, because it's very short acting. Adukku mattum dhaan use pannum, but glycoside is good, sir.
I saw one more question: postpartum hypertension. Rajshekhar?
Yes, sir.
Did you see any? Now I saw one question, postpartum hypertension. Yeah, in the after delivery also, after delivery, even after 10 days, somebody may have hypertension. There, postpartum hypertension, you can treat as normal hypertension. Only thing you must see whether the drug passes through breast milk. So you can continue levotalol, or you can change over to amlodipine or whatever drug she was taking earlier. Postpartum hypertension is like ordinary hypertension, but sometimes that hypertension will get better after 10 days. Usually eclampsia, pre-eclampsia, after delivery, the blood pressure comes down. So you will have to see and monitor after delivery. And if that continues, it may be a chronic hypertension, which followed by pregnancy, and then postpartum hypertension is the original hypertension. So you can continue the whole treatment.
And should statins be given to prevent the CV risk?
Statin definitely very useful. We are in India, we are underusing statin, and as Krishna Swaminathan says, by giving 3 rupees drug, you can prevent so many complications. And if somebody is eligible for in the criteria for statin, please put them on statin. All diabetic patients above 40 years, statin is a must. And anybody who has got that risk score, we have got risk calculators, and Lipid Association has given a risk calculator. And the risk calculator, if the risk is more than 30%, put them on statin. And that statin is lifelong. And people will, lot of WhatsApp message that statin produces muscle pain, statin produces this thing, that thing. All, not believable. Statin is well proved, a drug which can prevent complications. So statin can be easily given. Now, if the cholesterol, especially LDL, if there is a normal person, you reduce up to 70. They say 100. We all advise 70. Even if there is any risk, any associated risk factors, you can reduce up to 50 milligram also. So Lipid Association was the first to say that target. Now even the international guidelines say in a risky patients, you can reduce up to 50. So aggressive reduction is always good for people with high risk cholesterol. So LDL and non-HDL and lipid LPA, small a, all these things, you should see and then treat accordingly. Because nowadays we don't do serum lipid profile and we don't give statin. So I think that is one more area where we need focus so that we can prevent so many complications, heart attacks and the cerebral problems.
We must examine the patient from head to foot, not on one field alone. That is very important. Atherogenic risk, whatever may be the total cholesterol, if HDL low, it is an atherogenic risk. Whatever may be the total cholesterol level, if LDL high, it is an atherogenic risk. Whatever may be the total cholesterol, if triglycerides are high, it is an atherogenic risk. Atherogenic triad, that is high LDL, high triglycerides, low HDL. So this is an atherogenic triad. That is very important. We must keep it in mind. And dapagliflozin used in old age with congestive heart failure, Dr. Kishan Samnan, with the mild CKD, chronic kidney disease. Already, I think you have highlighted.
I don't think age should be a contraindication, sir, but be very cautious using it in the elderly. Possible hypertension, acute kidney injury should be on your thoughts as well. It is a
I
good,
saw one question, Rajshekhar, young hypertensive. Surprisingly, we got 1 in 8% above 40, below 40 years have hypertension in India. 1 in 8 below 40, they have hypertension. All these people, with Haribari, with the software industries, they develop hypertension.
Always adrenergic stimulation.
And the problem is, we don't diagnose them, so we miss the diagnosis, and they also don't take treatment. So young hypertensive is a problem. And as I said, young hypertensive, there is no contraindication. If it's a male, we can start ACE/ARB, beta blocker. If he's a female in the reproductive age, avoid ACE and ARB, and then advise them lifestyle modification mainly. Their haribari, heart curry, worry is always a problem. Ask them to have a good sleep, and then tell them to take home BP monitoring and monitor. So young hypertensive is a big problem now in India, and especially this computer age. So I think though they know all computers, they don't buy a home BP monitor and check. For them, I always tell, You go for artificial intelligence, see the internet, and see what are the problems of hypertension. So early diagnosis is not possible, and continued treatment is not possible because they are very complacent. Because it's a silent killer, they say nothing happens. They read only the side effects of the drug and say, by taking the drug, we'll have problem. Once you take the drug, you must take lifelong, like that. They have hesitancy.
See, congestive heart failure, that is the recent article, the Fantastic Four. Sir also has told that the Fantastic Four, my mnemonics bombs. It kicks, it knocks off the congestive heart failure with the especially reduced ejection fraction. That is the B for beta blockers, A for ARNI, angiotensin neprilysin inhibitors. Sir has told valsartan, sacubitril. Then M for mineralocorticoid receptor antagonist. Tribistat he has highlighted, brain aminopeptidase. That is the inhibitor activation. And the last but not least is, that is yes, that is SGLT2 inhibitors that Krishnan Swaminathan has highlighted, that is gliflozin. So the Fantastic Four, beta blockers, ARNI, mineralocorticoid receptor antagonist, SGLT2 inhibitors. Sir, iron deficiency anemia can cause increased HbA1c. Dr. Krishnan Swaminathan.
Can cause increased HbA1c. The logic எனக்கு புரியல. நான் தான் இத தப்பா
probably alteration of HbA1c.
Alteration வரலாம் sir. When the hemoglobin is less than 8, you've got to be very cautious in interpreting it unless you have a machine that can take care of the HbA1c variants, HB variants. Machine பொறுத்தது, but if it's a low hemoglobin due to any anemia for that matter, it can cause spurious values on HbA1c.
Yeah, especially in CKD, that is why the metabolic memory legacy effect, we all know, there is a superoxide anion radical that is because of the mitochondrial dysfunction. Mitochondria is the powerhouse storehouse of the factory. That causes three important, that is the nuclear factor kappa B, protein kinase C, and advanced N-glycation products. That is the cytokine pathway. That is very, very important. That is inflammatory markers. These are the inflammatory markers. That's why CKD, we have to be careful. Diabetes, the HbA1c assessment. Everything has got its own limitations. As like Petro Bruguda used to say, that is, beauty is an art of simplicity. Science is complex beauty that cannot be altered for the sake of simplicity. Very important.
Rashir, you were talking about iron deficiency.
Yeah.
And you are talking about heart failure. Sometimes, in a heart failure, you look for iron. And if you give iron, it definitely improves heart failure.
Yes, sir.
Nowadays, we use iron also as a heart failure.
Yes, sir. Iron carboxymaltose, IV. That also we have posted an article a few months back. Does vitamin D deficiency have any deleterious effect on type 2 diabetes mellitus? That also Dr. Krishnan Swaminathan has highlighted. That is, instead of vitamin D 60,000 units weekly once that patient was taking daily, that patient has developed a deleterious effect. Please, that's what they are asking.
Sir, Rashika sir, Munan sir, the patient's waiting. Now, FD sir, can I respectfully take leave?
Yeah, I think Dr. Sendil, are you there, Sendil?
Yes, sir. Sir, now can we have a short topic session by you, sir? Because some members are requesting.
Sendil, கேக்கல நீங்க பேசுறது கேக்கல.
Low tone.
Sir, can we have?
Can we have what?
Sir, can we have a short presentation of any other topic from your good self, sir? Because some members are asking for more and more academic piece from you, sir.
From whom? Krishnan Swaminathan or me?
நீங்க தான் சார், நான்லாம் ஒத்து ஊதுறேன் சார்.
No, I think Sendil for 2 hours மேல ஆயிடுச்சு. Will they tolerate our assault? We can talk for hours also. We can talk marathon also, but
Krishnan Swaminathan wants to leave because the patients are waiting. You can be here, sir. AM, sir, we will highlight a few points about hypertension.
Sure. Thanks a lot for the opportunity, Murugan sir.
Only one last question, Dr. Krishnan Swaminathan. Semaglutide and suicidal thoughts. With that, you can conclude.
ரொம்ப இன்ட்ரெஸ்டிங்கா இருக்கு சார். நான் ரொம்ப கேள்விப்பட்டது இல்ல, பட் ஐ அம் willing to learn சார். நான் போய் படிச்சுட்டு சொல்றேன். I don't think அது பெருசா தெரியல எனக்கு, but I'm not sure sir.
Yeah.
Thank you sir.
Thank you, Dr. Krishan Swaminathan. So about Krishan Swaminathan, very important thing what we must know is no two sulfonylureas should be combined. That is glibenclamide, glipizide with glimepiride, and no two SGLT2 inhibitors should be combined. No two alpha glucosase inhibitors should be combined. No two gliptins should be combined. Only drug that is allowed to be combined is the insulin sensitizers. One is guanides, that is metformin. Another thing is pioglitazone, because the insulin sensitivity tissues it improvement. Metformin has got improvement in central resistance of the liver and peripheral resistance, that is insulin sensitivity tissues too, that is the skeletal muscle. Another is adipocyte. That is one is that is the pioglitazone. It will have an improvement. These are the two important points. No two alpha glucosase inhibitors should be combined. So these are all the important points to be remembered. And regarding our Muruganathan sir talk, always a simple hexagonal approach to manage systemic hypertension. Thus, just remember my mnemonics: A for ACE inhibitors, ARBs. ACE inhibitors starting from captopril, enalapril, lisinopril, and ramipril, perindopril. He has highlighted perindopril, very long duration, about 17 hours of action. That is, and also there is also the HIVE trial, that is indapamide and perindopril, that is the HIVE trial. Hypertension in the elderly, it has got a very good effect. Indapamide is a thiazide-like diuretic. Another fee for blockers, beta blockers, alpha blockers. Beta blockers, we know starting from that is starting from atenolol, we don't use much because it is not a lipophilic beta blocker, because it does not cross blood-brain barrier and prevent sudden cardiac death. The other three important beta blockers, one is metoprolol, bisoprolol. Bisoprolol, long half-life, 12 hours are as told. Another is lebivolol. The advantage is L-arginine nitric oxide pathway influences, that is vasodilatation, very important. Another drug dialysable, that is a corvidinol. Another drug is lebitalol, that is especially for gestational hypertension. Alpha blockers, we know that is the prazosin, that is alpha blockers, we all know. But we have to be careful with the postural hypertension. Another C is calcium channel blockers, dihydropyridine derivatives, non-dihydropyridine derivatives. Dihydropyridine derivatives starting from nibidipine, that is amlodipine, azindipine, cilnidipine, so many dipines, even nitrandipine. Another non-dihydropyridine derivative is verapamil diltiazem. That is not a good antihypertensive. It has got a negative ionotropy. Be careful in using heart failure. That is A, B, C. Next is diuretics, that is thiazide diuretics, thiazide-like diuretics. Thiazide diuretics, chlorthalidone. Another thing is hydrochlorothiazide. Chlorthalidone more potent than hydrochlorothiazide. That is duration is also, that is 1.5 times more. Another thing is thiazide-like diuretics. One is metalazone, another is indapamide. Then D. Next is A, exercise, lifestyle modification, dietary approach to prevent systemic hypertension. That is to stop hypertension. Another D, E, F. Find out the cause for resistant hypertension. Is it due to the secondary hypertension or drug-resistant hypertension? That we have to be careful. Muruganathan sir. Sir.
Yes, sir. I think Share is sharing a presentation.
Sir.
Yes, I'm here. Actually, Sendil wants another 10 minutes or 20 minutes talk, because up to 6:45 he wants to keep the audience.
That is why prolonged.
Yeah, I can do a short talk on hypertensive crisis. If Sendil.
Yes, sir. Thank you, sir.
You can share whole.
Yes, sir.
Yeah. Can I share the screen?
Yes, sir. Yes, sir. You can share, sir.
Whole screen.
We are able to see, sir. Just make it
whole screen.
Maximize the presentation.
Yeah.
Okay.
Yes, sir. Done.
No, see, because Sendil has requested now already more than 900 people still waiting. I want to talk a short topic on hypertensive crisis. You know, what are the learning objectives in this is You unravel the terminology confusion, pathophysiology of evaluation, differentiate the presentation, to know different thresholds, targets, recommend antihypertensive therapeutic regimes tailored for specific treatment, to understand parenteral pharmacotherapeutic agents. Why? Because, I told you, you have to bring the target 130/80. But in a hypertensive crisis, you cannot bring it to 130/80. In chronic hypertension, yes, you can bring it to 130/80. In a hypertensive crisis, each situation has different threshold, different targets, different drugs and time frame. What is hypertensive urgency? What is hypertensive emergency? If the blood pressure is more than 180, 110, and there is no acute end organ damage, it is called urgency. If you have hypertension with end organ damage, it is called hypertensive emergency. We always call about malignant hypertension, where retinal hemorrhage, exudates, papilledema, renal involvement, malignant nephrosclerosis, usually BP of more than 130 diastolic. Whereas axillate hypertension, same, but there is no papilledema. So these are the older terminology. We don't use them. We always say my hypertension emergency or urgency. And why you want to know hypertension urgency, emergency? Because slide move. Okay. So all of you please learn how to use ophthalmoscope. Even as a GP, buy an ophthalmoscope and take the help of your ophthalmologist and see the fundus. In a early hypertensive, you get so many changes: grade 1, grade 2, grade 3, papilledema, etc. So you learn that by practice. Do you say above 180, 120 is the hypertensive emergency? Sometimes in a pregnancy or preeclampsia, even 150 on 10, suddenly somebody who's got 120, 80 goes for 150, 110 also, 150, 100 also can lead to emergency. Young person with acute glomerular nephritis, they may go for hypertensive emergency. And then how do emergency occur? Of course, you must know about the normal pattern, the cerebral control. This is very important due to endothelial permeability, endothelial dysfunction. These things can happen. I don't want to go into the pathogenesis now. I will only say very important, endothelial damage can activate clotting cascade, fibroid necrosis, and mechanical stress of the wall can produce vasoconstriction. All these things can produce pathogenesis of urgency here. And then here it is emergency, vascular injury. Again, I told you, this is cycle, vasoconstrictor release, tissue ischemia, vascular injury or occlusion. Now, the brain is a very excellent organ. Whenever there is a less BP, there will be vasodilatation, compensatory, so that there will be no ischemia in the brain. This can control up to say 180, 150 in a normal. In a chronic hypertension, if you see, even very big, very high hypertension also,
sir. Sir. Hello. Sir, it's not audible, sir.
Sir, Murugan, sir, it is not audible.
Sir.
Is it okay now?
Now it's okay, sir. Yes, sir.
Okay. Put on the slide. No, you will have to allow me to share the screen.
Yes, sir, it is visual.
Now done, sir. Yes.
Slide. Okay. Can you see the slides, Rashikar?
Yes, yes.
Yes, sir. Yes, sir.
Hypertensive emergencies: 1 in the brain, 2 in the eye, 3 in the aorta, and then heart, then kidneys and sympathetic, and then pregnancy, and then perioperative. So these are the hypertensive emergencies. And for hypertensive emergency, you should always there are approach like this. You first find out whether there is end organ damage. If the end organ damage, it is called emergency. If it is no end organ damage, it is urgency. For hypertensive urgency, you need not admit patients. You can observe, monitor, and then control blood pressure orally, oral drugs. In hypertensive emergency, you have a set of conditions where you have a general treatment goal. Exception to general treatment goal is aortic dissection, stroke, preeclampsia, or any clonidine withdrawal, etc. Now I'll come one by one very shortly. How do we treat general hypertensive emergency? For adults without compelling conditions, systolic blood pressure should be reduced by no more than 25% within the first hour. Sometimes, aggressively we reduce blood pressure. It can produce cerebral infarction, cerebral hypoperfusion. That is why in hypertensive emergency, don't be aggressive in all conditions. Except 3 or 4 conditions, you have to follow this rule. You reduce the blood pressure only 25% in the first hour. If stable, reduce up to 160-100 in the next 2 to 6 hours. Then cautiously to normal 140-90 during the next 24 to 48 hours. So this is the general principle. I was talking about hypertension management where I said you bring it to 130-80. Whereas in emergency, don't aggressively reduce the blood pressure because it can lead to cerebral hypoperfusion and can lead to hemiplegia and cerebral problems. Okay. 3 conditions where this is exception. Exception is aortic dissection, stroke, preeclampsia, and eclampsia. Now we'll come to one by one. We'll take first brain. Acute ischemic stroke, acute hemorrhagic stroke, hypertensive encephalopathy. These are the 3 conditions in the brain. When I talk about hypertensive urgency, 1 in 100 patients who have hypertension urgency, use correct technique. Let the patient sit in a quiet room, and then you reduce the pressure by oral drugs. If there's a persisting IBP, it's preferable to admit the patient for serial evaluation, investigations for potential hypertensive emergency, plan management, because hypertensive urgency can become emergency if you don't follow properly. And I already told you general rule, and the general rule I already told you for hypertensive emergency. In places like hypertensive emergency, 4 questions you must ask. What is the BP level at which one should start? How quickly should the blood pressure be reduced? What is the blood pressure target during this time period? How should this goal be achieved? I already told you for first 4 conditions, general approach, you reduce the pressure only very gradually, 25% only. And then after 6 hours, 160, 100. And then after 24 to 40 hours, 140-90. But 2 major concerns. Too rapid reduction may lead to stroke because hypoperfusion. Too slow reduction also lead to acute coronary syndrome or acute pulmonary edema. This I already told you. In a hypertensive urgency, you use oral tablets like clonidine, levetiracetam, hydrolysine. Don't use sublingual or buccal lipidipine. The choice of oral antihypertensive should be made on basis of underlying cause of the urgency and patient demographics and comorbidities. combination therapy can be used. So the drugs which you normally use, clonidine, labetalol, hydrozine, and labetalol, clonidine acts on 30 to 60 minutes, and it can reduce 22/10. But one important caution: don't stop abruptly clonidine because you get rebound hypertension. And then always confirm urgency. Don't lower BP too rapidly or too slowly. Prevent hypertensive emergency in urgency patients. And then goal of therapy, I already told you, 25% first, then 160, 100, and then 140, 90 after 24 hours. Always the level of blood pressure will allow gradual healing of necrotizing vascular lesions. And then coming to the aortic dissection, intracerebral hemorrhage, and preeclampsia. In aortic dissection, very important, you must rule out aortic infarction. It will mimic myocardial infarction. Aortic dissection may mimic heart attack. How do you differentiate heart attack with aortic dissection? Maximal abrupt onset of pain, tearing pain, and predominantly back pain, radiating down to legs below umbilicus, asymmetry of the pulses, acute AR. ECG may show ST elevation if coronary dissection. Only very important thing, you should not thrombolysis if you suspect aortic dissection. If you thrombolysis, patient may go for mortality. And immediate cardiothoracic surgical assessment is important. What do you do in aortic dissection? How do you reduce the pressure? Control the BP and heart rate. Maintain 120 systolic and heart rate less than 60. Achieve this target within 20 minutes. So, friends, that's why these emergencies are very important. You should know how to reduce the pressure. Also, what time. In aortic dissection, reduce the pressure in 20 minutes. And once you reduce the pressure with vasodilator, nitroprusside, or beta blocker, send them for cardiothoracic treatment. Again, labetalol, nicardipine, nitroprusside can be given. In a stroke, of course, as ischemic stroke, it can be subarachnoid hemorrhage, it can be hypertensive encephalopathy, or it can be cerebral hemorrhage. And in all those conditions, you should lower the BP to less than 185 to 110. And if the patient is ideal candidate for thrombolysis, give them thrombolysis. Friends, when somebody is going for stroke, you can prevent by controlling hypertension. In the window period, in the golden period, do thrombolysis, you can prevent or abort any hemiplegia or paralytic attack. That is why you should know about hypertensive emergency. I'm just rushing through this because I want to give you only points which you should know. Then hypertensive encephalopathy, if you treat and if you reduce the pressure, definite improvement will be there. Dramatic improvement after BP reduction. How do you diagnose hypertensive encephalopathy? By ruling out ischemic stroke and hemorrhagic stroke. How do you rule out ischemic stroke or hemorrhagic stroke? By doing CT scan. People like Sendil, they are doing excellent work in radiology. And once you do CT scan, then you will rule out whether it's hemorrhage or infarct. And this is the algorithm for ischemic stroke. Treat BP less than more than 220 by 120, reduce it. In acute intracerebral hemorrhage, don't reduce the pressure less than 150 to 140. In ischemic stroke, don't reduce the pressure very aggressively, gradual reduction. In subarachnoid hemorrhage, balanced risk of rebleeding, and you do nimodipine, one of the drugs which you use only in subarachnoid hemorrhage. Friends, I think this is the about the brain. Now I come to the hypertensive encephalopathy, rule of 25. I already told you. When the patient with encephalopathy have headache, confusion, nausea, vomiting, you give them antihypertensive drug, 25% in the first hour, and then at the end of the hour, another 25. So once the pressure is reduced, the patient will feel better. The drugs what you use in cerebral problems are nicardipine, labetalol, esmolol, and these are the parental drugs. You should not reduce aggressively, and you should not precipitate cerebral problem by hypotension, cerebral hypotension, hypoperfusion. And then comes the, I already told you about other conditions where you should be emergency. In preeclampsia also, you should reduce the pressure gradually. In eye also, in the grade 3, grade 4, use esmolol or labetalol and the parental drug to reduce hypertensive eye problem. And without compelling indication, the BP should be reduced to 25%. I already repeating again. Stable 160, 110, and then cautiously 24 to 48 hours. This is the drive home message for all of you. Don't reduce blood pressure in hypertensive emergency, except dissection, except stroke, except eclampsia. Your aim should be to reduce only 25% the first hour, 160 to 110, 100, 2 to 6 hours, cautiously 140, 90 after 48 hours. So the drugs we use is labetalol, nitroprusside, nicotine, phenyldiazepam, and all that. And always this is the aortic dissection I already told you. And then the drive home message is not all the patients who are having hypertension, you should reduce pressure aggressively. You should know when to reduce, what time to reduce, what drugs you should use. In acute coronary syndrome, when there is hypertensive acute coronary syndrome, you use labetalol injection, esmolol, nitroglycerin drip, nitroprusside, and a loop diuretic may cautiously use it. In hypertensive heart failure, you can use morphine also. In the kidney, you get acute pheochrosis, cocaine withdrawal also can produce acute emergency. And then I already told you about the other conditions, eclampsia, preeclampsia, and pheochrosis. For example, in a pheochromocytoma, when there is a tetrad of symptoms, you first give alpha blocker, then give beta blocker. I think eclampsia is very important because you have to save mother and fetus. If you cannot control in eclampsia with the drugs, delivery is the treatment of choice. The drugs which we can use is IV labetalol, IV hydralazine, nifedipine, long and short acting, nitroglycerin, nitroprusside as a last resort. Magnesium sulfate is for eclampsia and does not lower BP. Oral therapy followed by oral therapy, labetalol, nifedipine, methyl dopa. These are the drugs which you use, and you should know about these drugs, parenteral drug. And in an acute heart attack, you should always monitor, and you should not again lower the BP aggressively, but in a heart attack, you should reduce it aggressively so that you can prevent heart attack. So two things, if you want to save the brain, you reduce slowly. If you think you're going for a heart problem, you reduce aggressively. And the drugs which you use are, again, labetalol, esmolol, nitroglycerin. And then I already told you about kidney pheochrosis. And this is, because he asked me, suddenly I took the slide. So you have to understand the drugs. I'll give you last slides and then leave it to you. What are the drugs you should use? A drug which underlying pathology, treats underlying pathology, rapid onset of action, predictable dose response, minimal dose adjustments, highly selective, no increase in intracranial pressure, rapidly reversible, low risk of overshoot hypertension or adverse reaction, easy conversion to oral agents, acceptable cost-benefit ratio. These are the ideal drugs which can be used in acute crisis as a parenteral therapy. Unfortunately, we don't have a drug which satisfies all above criteria. And these are the drugs, just for completion's sake, you must know. If you don't know, please go and read. These are the drugs which will save your life in your practice. Sodium nitroprusside. Now, I start with faster acting to slower acting. Sodium nitroprusside is a vasodilator, acts within seconds, and then action is up to 2 to 5 minutes. You have to repeat the dose, you have to do drips. Esmolol is a beta blocker, starts 60 seconds, 10 to 20 minutes. Phentylamine alpha blocker, 12 minutes, 20 to 30 seconds. And the enalapril is the ACE inhibitor, the slowest, starts in 15 to 60 minutes and there 6 hours. So these are the parenteral anti-hypertensive drugs. Please read about these drugs. And in case of any emergency, you can use the drug. Always have this drug in your chamber and have the practice of using this by getting the advice from your senior consultants. And by doing this, you can save lives of many emergency patients. So summary and takeaways, I already told you in a hypertensive emergency, admit into ICU, rule out aortic dissection, severe eclampsia, and pheochromocytosis, where the exception to the rule of reducing it 25%, then reduce to 160, 110. Here you have to reduce aggressively. If there is these three conditions, reduce blood pressure less than 140 during first hour and less than 120, and then in aortic dissection heart rate to be 60. If there are no three conditions, I already told you, reduce by 25%, then 160, 100, and then next to 26, normal over 40 to 24 to 48 hours. In hypertensive emergency, reinstitute, intensify oral antihypertensive, and have a proper follow-up. So these are the emergencies which you have come across: ischemic stroke, hemorrhagic stroke, encephalopathy, acute heart failure, coronary syndrome, aortic dissection, renal failure, eclampsia, sympathetic crisis, pheochromocytoma. These are the conditions which you come across in hypertensive crisis. The most common cause of hypertensive crisis is uncontrolled blood pressure. So, ladies and gentlemen, why I talk about hypertension? You want to prevent hypertensive emergency and then problem mortality and morbidity, control hypertension. And then if the mortality is still high in a chronic hypertension,
slide size.
Mortality is still high. Control chronic hypertension properly to avoid acute hypertensive crisis for long-term benefit. And this is the hypertension soon turning out to be one of the most lethal disease in India. 29% people in India are hypertensive. People die due to hypertension in Southeast Asia each year, 1.5 million. And people in India with hypertension by 2025 is going to be more than 30 crores of people. So 33% in urban Indians, 25% rural Indians, 21% Indian men suffering from hypertension. So ladies and gentlemen, focus on hypertension. And then the most common cause of hypertension crisis is uncontrolled hypertension. So I think I leave you with this thought. Please, focus on hypertension. Have a best BP monitor. Promote home blood pressure monitoring. If possible, in your patients, when there is no control of blood pressure, at least do ambulatory blood pressure at least once. If you want ambulatory blood pressure, ask some of the pharma industries, they are giving free of cost. You check the blood pressure, rule out nocturnal hypertension, rule out BP variability, and ensure the control. It's a lifelong treatment. Advise lifestyle modification, because this is the very important message. When you say DASH diet, ask them to take plenty of vegetables, fruits, because fruits contain fiber, fruits contain potassium, which is good for hypertension. That is why in all my meetings, when I go as a chief guest, I tell them, don't give me flower bouquet, because flower bouquet is very costly and I don't use them. And when you give them, you give it to chief guests, they don't carry. But if you give a fruit basket with a small flower, they take it home. And that fruit basket contains fruits which are very good in fiber as well as potassium. So that message also for all your functions, give only a fruit basket or give nuts, because nuts nurture the heart. So ladies and gentlemen, this is the recommendation for somebody asked me about pregnancy. In severe hypertension, IV labetalol, oral methyl dopa, nifedipine. In perioperative hypertension, when you have a patient who's undergoing operation, perioperatively one can go for hypertension. So please avoid large perioperative BP fluctuation during the perioperative period. If the patient has got high BP, if there is an elective surgery, you can postpone the surgery. Abrupt discontinuation of beta blocker or centrally acting drugs is potentially harmful and it is not recommended. Transient preoperative discontinuation ROS blocker should be considered in patients with hypertension undergoing non-cardiac surgery. So management of hypertension, I already told you. So ladies and gentlemen, my dear brothers and sisters, I think I have talked much more about hypertension, and you will all agree with me. We need more hypertension specialists. We should have more hypertension awareness. With this, I hand over to Sendil. I think I have dragged up to 6:50 because Sendil requested me that I should continue up to 6:45. I continued up to 6:49. I think all the audience who are there in more than 50 people, if anybody is interested to organize any program on hypertension or diabetes or any, for that matter, any topic, we are ready to give you. I can take the help of Dr. Rajshekhar. We too have done more than 200 webinars in the COVID situation, COVID times. So any topic of your choice, it can be hypokalemia or hyponatremia, or it can be any genetic disorders, any complicated topic. If you want, please let us know. Senthil, we can organize and we can give very point by point, very clearly, and we can also get a good speaker and cover all the topics. I wish the CGP all success. CGP is a very important, I have a passion because I was a Dean IMA CGP in 2007, where I organized an excellent conference in Chennai. And then I only started a lot of CGP courses when I was the Dean. So I once again congratulate the organizers, Dr. Senthil Sengutuvan, Dr. Rajkumar, all the CGP people. I'll be happy to continue your series of lectures as per your choice. Thank you very much. And I thank Rajshekhar, who readily agreed when I asked him to moderate, and Krishnan Swaminathan also. I only asked him to talk on the good, bad, ugly of the drugs. I hope it is useful. If it is you have any doubt, somebody asked me to share my slides. Okay, definitely I can share any slide, any topic of the slides, because I got huge number of slides in my library. So any topic you can always ask to Senthil. I'll be happy to share. Thank you very much. Sharing knowledge is always very pleasurable. Knowledge is power. Knowledge is power when it is relevant. Over to you, Sundaram. Senthil.
Thank you very much, sir, for your kind lecture and nice lecture and experienced thoughts and everything. Thank you, sir.
Thank you, sir. And actually, there was one question in the chat box. Actually, can we have a same kind of session, same speakers, but different
Little more louder, please, Senthil.
Yes, sir. So we had a question in our chat box. Can we have a same set of speakers, different topics on a different date? So can we have continuous sessions like this? And now you have answered for this also, sir. So we are very happy to like that you have accepted our request, and we will continue definitely in future, sir. So
Senthil,
we will get the topics.
I have a passion for teaching. Same way,
Yes,
Rajshekhar. I have got my military army with a lot of knowledgeable soldiers and lieutenants and majors. So any topic of your choice, I can get good number of speakers and then control. Continue.
Yes, sir. Sure, sir. We will do it, sir.
Thank you.
We will do it, sir. And in spite of your busy schedule, you have given another surprise bonus topic also. I think it is very useful to all our participants. And almost 680 people are holding on now. And I think we had a wonderful session.
I have given the medical council credit points also, because when you asked me, I said, you got the points, no?
Yes, sir. Yes, sir. We have got 5 hours, sir, for the entire conference.
Yeah.
So
when you requested, I immediately told them to give you the points.
Yes, sir. Yes, sir. Sure, sir. Thank you, sir. Thank you so much, sir.
Even for AMS, they did the same thing. I gave them points.
Yes, sir.
And
yes, sir.
CGP also. So anybody who's organizing these programs in your respective IMA, please contact Tamil Nadu Medical Council. We'll give credit points.
Yes, sir. Yes, sir. Sure, sir. And tomorrow we have our inauguration of the conference. So this is a physical meeting which is going to happen at Pollachi. So all our state leaders, our CGP leaders, and even National Dean are coming. So I request all our faculties, moderators, and all our participants also who are, it is possible to drop and come in person at Pollachi. We are going to have a wonderful session tomorrow by 7 p.m. And tomorrow's session.
Senthil, sorry, I have to deny the pleasure because I told you I'm going to Dr. Mohan's diabetic conference, international conference, because I am one of the chief guests there. So I'm going tomorrow night. So I'll be,
yes, sir.
Yes, I cannot come.
Yes,
and I
you can just log in
pleasure.
during the inauguration session, sir, whenever it is possible. Yes, sir.
Yes, I'll be on the flight most likely that time.
Yes,
anyway,
sir.
Try.
Yes, sir. Please try, sir. And tomorrow's session is by 7 p.m. and it is not 6:40 for 3:45 p.m. So that is for our information of our participants. And now with this, I think we will end the session, and we have our vote of thanks and final concluding remarks by our Director of Studies, Dr. P. Sengutuvan, sir.
Thank you, Senthil. It is my pleasure to give vote of thanks for the eminence, experts, and moderators for their wonderful speech and wonderful question and answer sessions and shared their knowledge to the participants. I thank you, Dr. Muruganathan, Dr. Rajasekhar, and Dr. Kishan Swaminathan. Thank you on behalf of the CGP. I thank you once again, all the eminent speakers, for their sparing the session for this CGP. Thank you, sir. Thank you.
Yeah, thank you, sir. Thank you, Rajsekhar, sir.
Thank you.
We'll hope to meet soon, sir. Thank you, sir.
Thank you, sir.
Yes, sir.
Okay, Sandil.
Okay, Sendil.
Yes, sir.
It is
Yes,
a
sir.
long marathon, 2 hours and 50 minutes.
Yes, sir.
Almost 3
Yes,
hours.
sir.
Yeah, almost 3 hours.
Almost
And
3 hours, sir. 4 o'clock exactly we
only
started.
because of you, we stayed back, and because of me, Rajshekhar stayed back. Otherwise,
Yes,
he's
sir.
a busy practitioner. He would have gone by
Yes.
now.
Correct,
Anyway,
sir.
thanks.
Correct, sir. Yes, sir.
Thank you, sir.
Yes.
Shall we
Yes,
leave?
sir. Yes, sir. Yes, sir. Thank you, sir. Thank you, sir.
Thank you all.
Thank you, sir.